Welcome to week 1 home lecture. I understand this is a brand new concept for you guys, and I'm going to use some terms that you don't have any idea what they mean, and it might be a little bit overwhelming. I want you to do your best to take your notes for this lecture. When you come into class, we're going to talk about it again, and we're going to talk about it again. So be patient with your learning, and you're going to have a great time. So pregnancy, as most of you guys are aware, lasts 9 months. Now, out in the world, people date a pregnancy by the months. They say I'm 8 months pregnant or 9 months pregnant. But those of us who are practitioners typically go by weeks. So up here it talks about how pregnancy is lasts 40 weeks. It also has the days here, but none of us really know that. We usually go by weeks. So also in the next bullet here talks about somebody's due date. The most common abbreviation for that is the EDC, which stands for Estimated Date of Confinement. You might see EDB on a delivery room record, but honestly, most of the time you're going to see EDC. And you might be wondering how we calculate that. So what we typically do is we calculate a pregnancy from the beginning of the client's last menstrual period to the time of birth. For example, we use something called Naegele's rule. Now, Naegele's rule has been around forever. It was on my boards when I took my boards in 1993, so that was a long time ago. So that's honestly the most common method of determining somebody's due date. So what you're going to do is you're going to need to know the client's first day of her LMP. LMP stands for last menstrual period. So you're going to get that first date, then you're going to subtract the 3 months and add 7 days, and that will tell you when they're due, okay? There's also apps you can use on the phone. That's what most of us do anyway, and out in the hospital. But I would advise you, if you're going to be using your phone in the hospital setting, make sure you tell your patient, I'm going to take out my phone and look up your due date, okay? So you want to go ahead and do that. But this is how you do it without using a phone. We just talked about Naegele's rule, where you have to know the beginning of her last menstrual period. But what if somebody doesn't know that? Or what if somebody doesn't have a 28-day cycle that they can count on? If that's the case, what they're going to do is they're going to use an ultrasound to calculate the gestational age of the pregnancy. When they use an ultrasound, ideally, if it's up to the practitioner and in their perfect world, they would like to use a first trimester ultrasound. The reason is, if you think of a trimester, so let me pause. A pregnancy is divided into 3 trimesters. And we're going to go over this right here. Actually, it's right here, so I'm going to go down here for a second. So your pregnancy is divided into 3 trimesters. Your first trimester goes up until the 12th completed week. And then your second trimester goes from 13 to 27 weeks, and your third trimester goes from 28 to 42 weeks. So now circle back up here to the top here when we're talking about ultrasounds. So if we're going to use a first trimester ultrasound to date a pregnancy, that's the most accurate, because think of it, if somebody is barely up to 12 weeks pregnant, that's a very small fetus in there. And ideally, you want to be able to capture the entire fetus in one image. And a first trimester ultrasound makes it easy to do that. As you get farther and farther along in your pregnancy, they have to scan the entire abdomen as it grows, and you have to get the baby's images in more than one section of the abdomen. So ideally, you want to use a first trimester ultrasound to help date a pregnancy. But what if she comes into the hospital or in to see her doctor and they're in the second trimester? They would still go ahead and try to date this pregnancy by using an ultrasound, with the understanding that it might not be as accurate because she's past the first trimester. How they do that is they're going to measure the biparietal diameter of the fetus. And what they're doing is they're measuring the head and abdominal circumference as well as the femur length. So when somebody says that their due date is whatever, by an ultrasound, they get that by doing these measurements here. And that can predict the birth of the baby within 7 to 10 days. So it's a pretty decent way to date a pregnancy. We already talked about how pregnancy lasts 40 weeks. We talked about that. And I've covered your trimesters. You're going to want to keep the trimesters in mind because we talk about trimesters a lot of the time. So go ahead and try to keep that to memory as well. So quickening. So the next thing I want to teach you about is this word here. It's called quickening. Quickening is the fancy term for feeling fetal movement. All right? So you'll see that quickening is felt between 16 and 20 weeks of pregnancy. You might be asking, well, why is there a range? Why isn't it just at a certain time? The reason is because when you're first pregnant, you don't really know what to expect. You don't know that you don't know that you're feeling the baby move. Once you've been pregnant more than once, you know what it feels like. So for example, if you're pregnant for the first time you feel baby moving at about 16 to 20 weeks, it doesn't feel like a big movement. It's more like a flutter. So in retrospect, your patient will be like, oh yeah, I was feeling that, okay? But now if she has been pregnant before, she knows what it feels like. So that when she feels it on her second or third or fourth or subsequent pregnancies, she knows, oh yeah, this is fetal movement, and I know this. That's why I'm this many weeks. So this is why there's a range. Your fetal heartbeat can be heard by 10 to 12 weeks on a Doppler. Your normal fetal heart rate is 110 to 160. This is a typo, and forgive me. So your normal fetal heart rate is 110 to 160, okay? So next we're going to talk about the amniotic fluid and the umbilical cord. Both have a huge impact on how the baby grows and gets its nutrients during pregnancy. So let's first talk about the amniotic fluid. The amniotic fluid is a protective liquid in the amniotic sac that surrounds this growing fetus. Initially, it's generated from maternal plasma and passes through the fetal membranes via osmosis. At about the 16th week of a pregnancy, the baby's kidneys begin to start functioning. That's when the baby starts drinking in the fluid and passing it through the kidneys. Amniotic fluid acts as a cushion to protect the growing fetus as well as protect against umbilical cord compression. It also provides temperature control for the growing baby. It also allows for symmetric growth of the fetus. What I mean by that is, have you ever seen a patient or somebody who is contracted? If the fetus does not have enough amniotic fluid inside the maternal womb, it cannot open and close its arms and move its legs, so it becomes contracted. So we really want to have enough amniotic fluid to allow for symmetric growth of this fetus. It also prevents cord compression. I'm going to be teaching you this week on your first week of class how to read a fetal heart rate monitor and understand what cord compression is and how you can identify it, because you can't see it, but you can know the cord is being compressed because of how I'm going to teach you how to read the fetal monitor strip. But the amniotic fluid, because it's a cushion, it prevents the compression of the cord. So there are some abnormal variations to amniotic fluid. The first one we're going to talk about is this word called oligohydramnios. In the hospital, you're probably going to hear nurses just say the word oligo just because it's shorter. But what that means is that there's less than 400 milliliters of amniotic fluid inside the amniotic sac. When there's not enough amniotic fluid, these things up here can become compromised. The cushion, the temperature control, those kinds of things. You can have oligohydramnios for all kinds of reasons. One can simply be because her water's broken. Because if her water is broken, you're going to have less amniotic fluid inside that sac. That would make sense to you. Even if you haven't been in my class yet, you think that would make sense. But there's also other things that you're going to learn about over the next few weeks with me that can lead to oligohydramnios. The next word below it is something called polyhydramnios, and it's just the opposite of oligohydramnios. It means that this client has too much fluid. There's too much fluid surrounding this fetus, okay? So there's greater than 2,000 milliliters of fluid. That's a lot of amniotic fluid. Most of your nurses will just say the word poly, and what poly means is that there's just too much amniotic fluid there. So here over here on the right here, we're going to talk about the umbilical cord. The umbilical cord is very important. The umbilical cord should have 3 vessels. There should be 2 arteries that are small and 1 vein. And the way you kind of want to look at it, and we're going to watch a video in class in a couple of weeks, but if you were to look at the umbilical cord, your artery, you have 2 arteries on the top and a vein here. So think of it that way. All right? 2 arteries and 1 vein. The umbilical vein carries oxygenated blood from the placenta to our fetus, and the arteries carry deoxygenated blood away from the fetus to the placenta. And I put a little memory aid here. It's probably from all my years teaching pharm. Memory aids really are very helpful when you're trying to learn all this new stuff. There's something called Wharton's jelly. Wharton's jelly is just let's use this picture here. So here's the arteries, right? And here's the vein. And everything surrounding those vessels, all in this picture here, all this shimmery stuff, that's Wharton's jelly. All that jelly does is provide the cushion around the vessels so they don't get squished and they don't get compressed, okay? So Wharton's jelly is very important. This middle picture here will show you that you can have things in your umbilical cord like knots. A knot in the umbilical cord can be problematic. I want you to picture right now, if you're washing your car and the hose is on full blast. So on one end of the hose is the water that's coming out. That's how you wash your car. And on the other end of the hose, it's attached to wherever, the house or wherever. And that's where allows the fluid, which is the water, to go through this hose segment. If you were to compress that hose, whether you step on it with your foot or you bend the hose in half, the amount of fluid, which is the water, coming out the other end is going to be less. Okay? So think of your umbilical cord as kind of the same idea. Inside the hose is water. Inside your umbilical cord are vessels that carry blood. If that umbilical cord is compressed, the amount of blood coming out the other end is going to be decreased. And it can be compressed by all kinds of things. It can be compressed because it's squished laying next to the arm of the baby. It can be compressed because it's wrapped around the baby's body. It can be compressed because there's not enough fluid to keep the cushion there. It can be compressed because there is a knot in the cord. All right? You don't know any of this stuff by looking at your pregnant patient, but you can tell that there's compression because you're going to learn how to read the fetal monitor tracing. So let's look at this picture here. We've got, I'm not going to use red because there's red in there. We've got this tight knot right here and a loose knot. Let's start with the tight knot. Now again, I'm trying to have you guys visualize things. If you're tying your shoe and there's a really tight knot in the shoelace, you really have to work hard to get that out. Sometimes the knots are really, really small and you have to use something sharp to get the knot undone. Thinking then, if there was a tight knot in your umbilical cord, the tighter the knot, the less blood flow that's going to go to that fetus. And the less blood flow that goes to that fetus is going to increase the amount of compromise that baby's and hypoxia that baby's going to have. Sometimes when you have a fetal demise, which means the baby that is dead when it's born, you might see a string of knots because somehow that umbilical cord got tied into so many tight knots that the blood flow to the baby was cut off. But you also have loose knots. So again, I want you to think of your shoelace. If you had a big loose knot, you could very easily untie it. The looser the knot, you have less compression. Again, think about the hose. So that's how the knots kind of work out there. This picture on the right, see this little bulby area right here? This is all Wharton's jelly. So this whole thing is Wharton's jelly. But you might see an umbilical cord that has this little bulby thing right here. That's fine. Don't worry about it. It's just Wharton's jelly. When somebody is pregnant, they receive a series of blood work and different screenings during their pregnancy. When they first come in and see the doctor, they're going to have these above tests be performed on them. They're going to do a CBC, which stands for complete blood count, which you guys probably know because you're third semester students, but that's what it means. Also, they're going to be doing an HIV screening. If your client is HIV positive, they will go ahead and deliver by a C-section at 38 weeks gestation. They should be informed that they should not breastfeed, and everybody should handle the newborn with gloves until it receives its first bath. Also, the newborn should not receive its newborn medications until after the first bath. Next, we're going to talk about ABO and Rh typing. This determines the risk for maternal fetal blood incompatibility. Rh incompatibility occurs during pregnancy if the mom has Rh negative blood and her baby has Rh positive blood. It is very rare to have fetal and maternal blood mix. The biggest risk of this happening is in any kind of traumatic situation, like abuse or an auto accident, miscarriage, amnio infusion, a tubal pregnancy, or an ectopic pregnancy. That's the same thing as tubal pregnancy. Or any time that there's a chance of blood mixing, and that can happen at delivery in a very rare occasion. If the client has Rh negative blood, they're going to receive something called RhoGAM, and I'm going to write it here. What this is, it's a Rh immunoglobulin. They typically get this at about 28 weeks gestation. Once the client delivers, we will check the baby's blood type, and if the baby is Rh positive, the client will get a second dose of the RhoGAM. This is going to be repeated each time the client gets pregnant. If the client is exposed to Rh positive blood and does not receive the immunoglobulin, like RhoGAM, it leads to issues in subsequent pregnancies. And the next time they become pregnant, if she didn't get the injection, the antibodies that was made in the first pregnancy will cross the placenta and destroy fetal blood cells, which can lead to fetal anemia. So it's really important that we always know the client's blood type and Rh status. They're also going to do a urine culture, screening for urinary tract infections, because urinary tract infections can lead to preterm labor. They're also going to do a screening for STIs, so we're going to call them TORCH infections, and TORCH is just an acronym. The T stands for toxoplasmosis, the O stands for other infections like hepatitis and mumps, the R stands for rubella, the C is cytomegalovirus, and the H is for herpes. So for toxoplasmosis, this is passed in the feces of domestic cats and by consumption of raw or undercooked meat. The rubella, women must have their blood drawn to assess the rubella status when they're pregnant. If they are non-immune, they will go ahead and get immunized in the postpartum period. Once they get immunized, they should avoid becoming pregnant for a month after getting that vaccine. Cytomegalovirus is a member of the herpes family. There's not really a treatment for this. It can cause fetal hydrops, and fetal hydrops is an accumulation of fluid around the fetus. It can also cause IUGR, which stands for intrauterine growth restriction, polyhydramnios, cardiomegaly, and fetal ascites. Herpes can cause a miscarriage. It can also lead to preterm labor. It also can be passed to the fetus if the mom has a current outbreak during delivery. Herpes can remain dormant a lot of the times, but pregnancy is a stressful state on the body, and pregnancy can bring out and exacerbate herpes. If somebody has an outbreak of herpes when they're pregnant, they'll take acyclovir near term to treat that outbreak. Other STI infections like chlamydia. If chlamydia is left untreated, it can lead to pelvic inflammatory disease, which can also lead to infertility. All pregnant women are screened for chlamydia in the first trimester and then rescreened again in the third trimester if they're younger than 25 or if they are high risk. We treat infants with erythromycin eye ointment following delivery to provide prophylaxis against chlamydia. Gonorrhea also can be passed to the newborn during delivery. So we're going to treat the baby again with erythromycin eye ointment to prevent any kind of transmission of that. Syphilis also can be passed to the newborn during delivery. The test that we screen for syphilis is called a VDRL. It's either negative or positive, and that's a syphilis screen. And HPV are genital warts, and they can lead to cervical cancer. It is recommended that between the ages of 11 and 12 years old, young people get their HPV vaccine to prevent certain cancers that come with this. And finally, bacterial vaginosis. It's the most common vaginal infection in women ages 14 to 49. It is not always related to sexual activity, but it can be associated with preterm labor. Finally, we're going to talk about something called group beta strep. Sometimes it's called GBS, sometimes it's called B strep. It doesn't matter. It's all the same thing. What it is a bacterial infection that can be passed from the fetus to the mom during labor. It can cause pneumonia, RDS, sepsis, and meningitis in the neonate if it has GBS. How we screen for this is we do vaginal and rectal cultures between the gestational age of 35 and 38 weeks. If the client is GBS positive, they receive antibiotics when in labor. And then we're going to watch the baby a little bit closer when it's born, and they may do some blood work on the baby to make sure it does not have GBS. So you might be thinking, how do I house all this information? Where do I find all this information? There's something called a prenatal record that's going to house everything that has happened to your client up until the time you met this client. So whenever they go to the doctor and they have their blood work done and their weight, ultrasounds, it's going to be found on the prenatal record. It is expected that all labor nurses, postpartum nurses, and nursery nurses, as well as all of my students, make sure you look at this every time you're in the hospital. It will let you know everything that the patient has had done since they became pregnant. We also are going to screen for gestational diabetes between 24 and 28 weeks gestation. A couple of things about gestational diabetes. Typically, somebody who has gestational diabetes, once they deliver, their blood sugar tends to go back to normal, and most of the symptoms, if not all of them, disappear following the pregnancy. Your ideal blood sugar is here, 70 to 110. Some risk factors for gestational diabetes: obesity, hypertension, somebody over the age of 25, a family history, and a previous delivery of an infant that was large or stillborn. This will list the insulin needs by the trimester. So you see in the first trimester, you don't need as much insulin. But then as the fetus begins to get bigger and larger and grow, you'll see the insulin needs keep rising and rising, okay? Until the client delivers, then there's going to be an abrupt decrease in that insulin requirement. So now we're going to talk about how to assess your patient in the intrapartum period. So you're somebody who's pregnant is going to be on the fetal monitor whenever they're being assessed, because we always have two patients, sometimes three if she has multiples, or four, but we have the pregnant client as well as their unborn child. So we have to make sure that both are stable. And how we assess this on the fetus are the presence of fetal monitors. In orientation, I'm going to teach you how to apply fetal monitors and how to read the fetal monitor so you have a basic understanding of what that means. But in a nutshell, the external fetal monitors, that's the key word, it's outside of her body. There's two pieces to it. There's a Doppler or an ultrasound, it's one piece, that measures the heart rate of the fetus. And the tocodynamometer, we just call it a toco because it's a big word. This measures the client's contractions. The internal fetal monitor goes inside the client's body. There's two pieces of it. The internal fetal monitor picks up the heart rate of the baby, and the intrauterine pressure catheter picks up the contraction strength of the client. And again, we're going to go over these in much detail during orientation, so just kind of put a pin in that until we do that. So there's a specific interval on how often we assess our clients when they're in labor. Now, it's going to depend on what stage of labor that they're in, which I'm going to teach you as well. As they progress through labor, we stage their labor. And as they get closer and closer to delivery, we're going to monitor the baby and the client more often, which would make sense. So we're going to talk about that as well. And then once the client's membranes rupture or their water breaks, we're going to have to assess for hyperthermia as well. So back in about 2008 or 2010, the NICHD composed what you're seeing here. Before then, we always kind of, as labor nurses, we all had to describe on the phone to our docs what we were seeing with this baby, right? We would get on the phone and we would describe narratively what we would see. And then we would get orders from the doc that would tell us what to do based on what I was telling them over the phone. So I'm hoping you can see there's lots of room for interpretation there, whether it's good interpretation or bad. So there was lots of discrepancies. So nowadays, we categorize fetal heart rate tracings this way: Category 1, Category 2, and Category 3. I'm going to teach you how to do this the way that I was taught how to do this back when it came out. So let's go ahead and let's talk about everything that's in a Category 1 tracing. That's this green circle here. So I want you to learn what is a Category 1 tracing. You've got your fetal heart rate of 110 to 160. That's normal. We have moderate variability, which you'll keep learning about this, okay? Absent decelerations, and absent late or variable decelerations, and you can have accelerations too. Now you're sitting here thinking, I don't know what any of those words mean, and I totally understand that. I'm going to teach you what this means the next time we're together. So anytime your baby's strip has any of these descriptors, they have a Category 1 tracing. Now let's go to the Category 3 tracing. So when you're reading the baby's strip and you're seeing absent variability as well as, see, it has to have the and, that's the kicker. So if you have absent fetal heart rate variability and any of these things here, you have a Category 3 tracing. And then everything else is Category 2. So don't learn everything in here. The easiest way to learn it is learn everything in Category 1 and everything in Category 3, and whatever is left is in Category 2. So now you're probably sitting there thinking, well, what do I do with this? This tells us what the next thing to do is. If you've got a Category 1 tracing, you know that your baby is being adequately perfused at the time that you're reading the tracing. So you know the baby's doing okay. If you have a Category 2 tracing, that means that you still need to observe the baby a little bit more. Further assessments need to be done. You're kind of in that equivocal stage. You're not sure if it's bad, you're not sure if it's good, so you just need to hold on it and wait and then keep doing evaluations. If you have a Category 3 tracing, this is why it's red. This needs to cause you to stop and do something about it. And if you can't fix the Category 3 tracing rapidly, the client will end up having a cesarean section. So here's an example of a Category 1 tracing. I'm going to give you an overview of this. I know you don't really know what it means. I'm going to teach you. So on the top, so your fetal monitor paper is divided into two sections. The top part will always tell you the fetal information. And the bottom part is going to tell you the maternal information or the contractions, okay? All right, so let's look at the top part here. So there's an order of operations when you're going to be reading a fetal heart rate tracing. Sorry, my dog is snoring, so forgive me. I apologize. So you're going to assess the baseline first. So let's go ahead and write that first. So you assess the baseline, and you assess the variability. And then you assess for accels, and you don't know these words yet, or decels. All right? So the baseline is the number. So what you're going to do is you're going to try to find, you can't count during contractions. That's a contraction, and that's a contraction. So right here, I would say that could be a good baseline. So that to me is a baseline. If this is 120, 130, this baseline here is 140. 140 beats per minute. The variability are the squiggly line, the squiggly beat to beat of your baseline. And it comes to be moderate, minimal, or absent. And we're going to talk about this in detail and orientation, okay? So this, and then the accels are the things that go above the baseline. And then decels, you don't have any on this strip, but decels go below the baseline. So this is an example of a category 1 tracing. You have a normal baseline. You have moderate variability. And you have some accels. So this is a category 1 tracing. A category 2 tracing, you can see it a little bit different. And again, even if you don't really know what you're looking at yet, which I know that this will come by the end of the week, you're going to have a little bit of better understanding about this. But let me just kind of give you an overview here. So these here are contractions. Okay, see that it just kind of goes up a little bit. And this is your baseline. We kind of talked about that on the former slide. So I would say my baseline here is 155. If you said 160, I wouldn't argue with you, okay? So our baseline is 155 or 160. We have moderate variability, but what's happening here, the fetal heart rate is dropping below the baseline. Those are called decelerations, okay? So a deceleration means that it's a category 2 tracing. And a category 3 is a little more ominous here. We can have a sinusoidal pattern, which I know you probably have heard that phrase before. Typically, sinusoidal patterns like this let me know the baby might have some fetal anemia happening, so that's a category 3 tracing. Or do you see how this baseline here, even if you don't know how to read the strip, you can see how it's kind of flat? That is not a good sign, okay? You don't want to have absent variability as along with these decelerations. So this to me is a category 3. This baby is telling me, nurse, I'm not doing well. Help me. Get me delivered before something happens to me. So next we're going to talk about labor and birth terminology. These words are going to become very familiar to you. Antepartum, intrapartum, and postpartum. Antepartum is the time between conception and the onset of labor. Intrapartum is the time between the onset of labor to the birth of the infant and the placenta. And then postpartum is the time from birth until the time when the client's body returns to the non-pregnant state, typically about 6 weeks. So now we're going to talk about pregnancy terminology and birth terminology. I want you to kind of divide this slide in half. Boy, that looks messy. I apologize. Okay. Let's talk about the pregnancy terminology first. Gravida. We're talking about gravida. So gravida is the number of pregnancies your client has ever had. Gravida includes miscarriages, abortions, anything. Anytime they've ever had anything in that uterus, gravida. A nulla gravida is a client who has never been pregnant. So those of you who have never been pregnant, that's you. A prima gravida is a client who's pregnant for the very first time. Out in the world, we just call those primes. And a multigravida is a client who has been pregnant 2 or more times. And again, we call these clients multips. So now let's shift over to birth terminology, and that is para. So the para is defined as a birth over 20 weeks gestation, regardless of if baby was born alive or dead. Now we have a nulla para is somebody who has never given birth at more than 20 weeks. You're going to see this commonplace here. A prima para is somebody who has had one birth at more than 20 weeks, regardless if that baby was born alive or dead. A multipara is a client who has had 2 or more births at more than 20 weeks gestation. And a stillbirth is a fetus that has been born dead after 20 weeks gestation. So some commonalities here is 20 weeks. You see that. It's all over here. So there's this word here called viability. Viability is the point in the pregnancy where the infant can survive outside the uterus. Typically right now, with current research, that's about 24 weeks gestation. A while ago, when I was born, a long time ago, it was a lot higher than this. As more research is being done, they're working on and I bet the gestational age will get lower and lower. So we're still talking about pregnancy and birth history here. I've taught you about gravida and para. So we're going to keep talking about gravida and para. Now, I just told you that gravida is the number of pregnancies your client has had that is including the one that she's currently pregnant with, if applicable. And para is birth history. So, but sometimes that doesn't equal up. So, for example, let's talk about somebody that has been pregnant twice and has 2 kids. So she is a gravida 2, para 2, right? That means they have had 2 pregnancies and 2 deliveries. But let's talk about somebody like me. If you were to work out my G's and P's, I'm a gravida 3, para 2. Well, you guys might be wondering, or somebody should be thinking, well, why don't these numbers add up? Something is off there. What we do is we can delineate the acronym TPAL that helps us understand the birth history. So the acronym TPAL stands for term, preterm, abortions, and living. I'm going to read this to you, and then I'm going to go to the next slide, and I'm going to work it out for you, and you'll understand it. We can do it together. So T stands for the number of pregnancies delivered at 38 weeks or greater. P stands for preterm, so the number of pregnancies delivered between 20 and 37 weeks and 6 days. This can be written 37.6, 37 plus 6, and 37 and 6/7. All this means is that she is 37 weeks and 6 days pregnant. A lot of my students get P for preterm, get confused with they mix up preterm and para. Remember, we're talking here about preterm. The A stands for abortions. It's the number of pregnancies ending in spontaneous or therapeutic abortion prior to viability. A spontaneous abortion is a miscarriage. And how I would ask her that is if she's ever had any miscarriages or abortions. And I just say it straight out like that, and then they'll tell you. Hopefully they tell you. And then living, how many number of kids they currently have living. So let's work out my G's and P's. All right? Make sure you have written down or in front of you what each of the TPAL means. So G, I told you I'm a G3, P2. So G means gravida. So here I would tell you I've been pregnant 3 times. Okay? That's what that means. And I have 2 living kids. But we're trying to figure out what happens with the other number. So what we're going to do here is do T, P, A, L. Okay. So term. How many babies did I had term? I had 1 term baby. How many babies did I have preterm? I had 1. My youngest daughter, who's 25 now, I had at 37 weeks in like 1 day. So I had how many abortions did I have? I had 1. I had a miscarriage at 10 weeks before I had my first child, and she's 26. So I had 1 miscarriage. And I have 2 living, I can't spell, sorry, girls. Okay, so here's my 3, right? I've been pregnant 3 times. And this is what happened with all 3 of the pregnancies, but I have 2 living children. There are different theories of how labor starts. There can be maternal factors and there can be fetal factors. Some of the maternal factors is that the uterus, so the uterus is just a muscle. When somebody's not pregnant, it's about the size of your fist. As they get pregnant, the muscle gets bigger and bigger and stretches, and as it stretches, it releases prostaglandins, and prostaglandins can cause irritability in that muscle, which can be contractions. That's one. Also, you can have pressure on the cervix from the fetal parts. As the baby is sitting on the cervix, it causes pressure, which releases oxytocin. And oxytocin can cause contractions and some cramping as well. Oxytocin levels become increased more rapidly as we get closer to our due date. And during labor, our estrogen progesterone shift. So in the beginning of our pregnancy, we want the estrogen to be low and the progesterone is high. Progesterone helps maintain a pregnancy, and estrogen can cause a little bit of contractility. But as we get closer to our due date, the estrogen's going to go up and the progesterone's going to go down. So this is the estrogen and this is the progesterone. And then it causes contractions. There can also be some physiologic changes that happen before somebody goes into labor. Sometimes, not all these have to happen, but sometimes they do. So I just want to teach you about them. Somebody can say their back hurts because their muscle is relaxing, that pelvic muscle is relaxing. But then you think about someone like me, my back hurts all the time because I have an injury. So, hit or miss with that one. Some clients experience a weight loss just before they go into labor. There's something called lightning. This word lightning is not the lightning in the sky. Lightning is the baby's dropping in the pelvis. So typically, this is noticed only in prime gravida clients about 14 days before the labor onsets. We have this feeling of the baby dropping into the pelvis. That's lightning. The client's going to start experiencing some irregular contractions. Those are called Braxton Hicks. And then those irregular contractions progress to be stronger and stronger and stronger until she's in full-blown labor. They might notice the passing of blood, vaginal bleeding, or mucus plug because that cervix is becoming thinner and softer. Some clients notice a burst of energy, which is called nesting. Some women or clients, as they're getting closer to labor, their water breaks. What we need to know is that doesn't happen to everybody. Some people, and the water never breaks by on its own. The docs have to do that because in California, we can't do that as nurses. So when somebody's water breaks, typically their labor will start 24 hours after their water breaks. So hopefully she's term. If her water breaks when she's preterm, that's a different conversation. We have that conversation in a couple of weeks. So how do you know if her water's broken? Well, if you watch anything on TV, when someone's water breaks on TV, they're just covered in fluid. That doesn't always happen that way. It depends on where the hole in the membranes are. If the hole in the amniotic sac is low over the pelvis, then the client will see lots of fluid coming out. But sometimes the hole is up on top of the membranes or over to the side, and they're unsure. They'll think, I don't know if I'm peeing a little bit. They don't really know. They can't establish this. What they need to do is come into the hospital and have us, the labor nurses, figure it out. So how we do it are two things. We can use something called pH paper or nitrazine paper, and we can do something called a Ferning test. So I'm going to tell you the most conclusive way to diagnose somebody's ruptured of membranes is a Ferning test. The reason is because nothing looks like it except for the fern of plant and amniotic fluid. Okay? How we do that is we put a speculum inside the vagina and try to get some fluid on a Q-tip, and we put that fluid from the Q-tip on a microscope slide, and then under the microscope it looks just like that. So for nitrazine paper or pH paper, it typically is this yellowy color right here. And if you put this yellow piece of paper against amniotic fluid, it'll turn this bright blue color, which is great. The problem is semen turns it bright blue, urine turns it bright blue, so it's not as conclusive as the nitrazine. So next we're going to talk about how to figure out if somebody is in true labor or in false labor. And that can be hard to establish unless you're the labor nurse. This really can only be done by the labor nurse. Let's talk about false labor first. Somebody who's in false labor, their contractions, now it's hard because pain really is a subjective thing. I have a very low pain tolerance, so I may tell you I'm in a ton of pain, but somebody else might say it doesn't hurt at all. So just pain's kind of a tough one, but I would tell you that the contractions are irregular and they're far apart on somebody who's not in labor. If your client gets up and walks around, those contractions typically will go away. And they're going to feel these contractions more at the umbilicus and the lower abdomen, only kind of over the bladder. And when they lay down, the contractions go away. One big hint is if somebody's in labor, true labor, nothing makes them go away except delivering the baby. When somebody's in labor, the contractions get closer and harder and stronger until the baby's out. So all of these things would tell me that somebody might not be in labor. If I were to check this client's cervix, there would be no change in effacement or station or dilation, and the baby would not be engaged in the pelvis. Somebody that's in labor, I already told you the contractions are stronger, more painful, and more frequent. They typically start in the lower back and they radiate to the front across the abdomen. When the client gets up to walk around, they don't go away, but they get stronger and stronger. If somebody's in labor, dilation of the cervix happens along with effacement as well, and the baby engages into the pelvis. So let me give you a scenario to help you understand kind of what this all means, because I know this is brand new to you guys. When somebody comes into the hospital to be seen, they're always put on the monitor because you have to assess the fetal well-being as well as maternal well-being. So if somebody comes into the hospital and says to me, I think I'm in labor, I'm going to ask them narratively, as long as everything is safe and they can talk and all of that. How far apart are your contractions? How strong are they when they start? Those kinds of things. Then I'm going to put the client on the monitor. And then let the client sit there for about 10 minutes, see if I can pick up any contractions, make sure the baby's doing okay, and then I'm going to check their cervix. If the baby is a category 1 tracing, I'm going to have the client get up and walk around for an hour. And then I'm going to have the client come back an hour later, and I'm going to check her cervix for a second time. So the first time is my baseline. Just like baseline labs, the first time is my baseline. So say, for example, I check her cervix, and she's 2 centimeters dilated. I have her get up and walk around for an hour, have her come back, put her back on the monitor, get a 10-minute tracing so I can establish fetal well-being, and I check her again. If she's still 2 centimeters dilated, she's not in labor because there is no significant change in dilation or effacement. She's probably going to go home. But if I check her the second time and now she's 4 centimeters dilated, she's effacing more, she's in labor, these contractions are causing cervical change, and she'll be admitted for labor. The only true diagnostic for labor is cervical change. So we need to make sure that we provide culturally competent and patient-centered care, especially if our clients are in labor. You'll notice that one of my favorite assignments that we do is our culture assignment for people in labor. Different cultures have fascinating ways of supporting these pregnant clients, and we need to make sure that we're aware of all these. This is a very generalized overview of some of the ways we can be culturally competent to our client who's in labor. Our Hispanic clients might prefer their mother to be there rather than their partner. Our African American clients may prefer female family members to be present. Our Asian American clients might prefer their mom to be there, okay, or they might progress through labor in a silent form. Our Native American clients might prefer female nursing staff. They like to use lots of herbs when they are in labor, and they typically like to squat for the birth of their baby. So there are 4 stages of labor. I'm going to go over it initially with you here, and we're going to talk about it for quite a bit when you guys come to class. Assessing your patient through the stages of labor is a foundational piece of supporting them when they're in the labor process. So the first stage of labor is the very beginning. It's actually kind of like the dilating stage of labor. The time from their cervix is closed to when it's 10 centimeters. So a lot of internal work is happening here. We're going to assist our client with positioning and pain management. We're also going to be monitoring the fetus. We have to. Don't forget, you have 2 patients. You have the pregnant client as well as the fetus. We're going to talk about pain management. Like I said, you can do epidurals, you can do other kinds of pain meds, like pharmacological, like opioids for pain meds. You can do other things, but you want to make sure that you know what the client would like and help support them. We need to watch for something called hyperventilation, which you know what that means. You've been around for long enough to know what that means. But hyperventilation is really common in this first stage of labor. The first stage of labor is very hard and painful. And it's also going to be very scary. So it's not uncommon that your clients start hyperventilating. They may not even know they're doing it, but they're going to tell you that they're lightheaded, they're dizzy, they may have tingling in their fingers. How you help them is to kind of get control of them. Say, look at me, and breathe with them. Try to slow their breathing down. You can have them make their hands into a little cup and put the cup over their nose and their mouth and breathe into their cupped hands at a slower rate. You may have to count for them to keep them really focused and to bring them down to a more manageable rate of their breathing. Your second stage of labor is actually the pushing stage of labor. Okay, there's different phases we're going to talk about when we're in class, but this is when our client is delivering her baby. So she is fully dilated here. I didn't write that other one. Hold on. And this one I should have written 0 to 10 centimeters. That's that one. All right. So here she's fully dilated, and she's going to be delivering her baby. We have continual assessments of the mom and the fetus. Continual. When you have somebody who's pushing and having their baby, you don't have any other patients except the one that you have. That's it. Because you're continually at the bedside. You don't leave the client there and by themselves. Ideally, you'd like them to have open glottis pushing, means that they don't hold their breath. They may push every other contraction. That's okay too. The hard thing is when you guys go into the hospital, you're going to see your nurses and your docs tell your patient, take a big breath in and hold it and bear down and push. That, I'd love to tell you that it's going away, but it's not. Evidence says that you shouldn't do that, but everybody instructs their patient to do that. So you're going to have to kind of navigate your way with that, but know that the babies don't do as well if the mom holds her breath. That's called closed glottis pushing, and it can lead to fetal hypoxia and acidosis. So let's talk about pain management in labor. So labor hurts, and I know that sounds funny for me to tell you guys that, like you're thinking, well, of course, but I can't tell you how many people I met over my years and years and years of being a labor nurse that were surprised at how much it actually hurts. It certainly is better to have this conversation before she's in labor. But regardless, here are the things that I'm going to teach you about. I'm going to teach you about the non-pharmacological ways you can manage your pain. There's probably more than I have here, but that's okay. So childbirth education, you can go to childbirth classes. They used to be called Lamaze classes, but basically you're going to meet an educator at the hospital where you're delivering, and they're going to teach you about labor and how you breathe with your contractions. Nice, controlled breathing. There also are people that are doulas. Many of you guys might have heard of somebody that's called a doula. What a doula is another person that their only job is to assist with labor and pain management. They're not nurses most of the time. 90% of the time, they're not nurses, but they're contracted. The pregnant couple will contract them, and the doula will come to the hospital with the pregnant couple and help them breathe and relax and all that jazz. I just saw a video yesterday about hypnosis on YouTube, about hypnosis in labor. I find it fascinating. I've never had a client use this, but whatever floats your boat, I think it's great. Some people use biofeedback. They use effleurage. Effleurage is basically what that is they can lay in bed or sit kind of in a semi-phallus, and they use the tips of their fingers, and you're going to run your fingers. You kind of start at your where your sternum is, so the top of your abdomen, and then bring your fingers out bilaterally on both sides of the abdomen till you get to the pubic bone and come up through the middle and back out again. Okay? And nice big breathing when you're doing that. That helps relax lots of people. I have seen a patient use a TENS unit when they're in labor, so you can do that. Counter pressure, we can do that, and application of heat and cold works as well. So now we're going to talk about pharmacologic pain management. That includes analgesia and local anesthesia. Things like IV narcotics and epidural is what we're talking about here. So we can talk about sedatives. We typically give sedatives to somebody in the very beginnings of the first stage of labor. And they help kind of relieve some of the anxiety and help our clients get some sleep so they can get through that piece of that stage of the labor. Once labor is established, which means they're having strong, regular contractions that are changing their cervix, we can give them opioids. That will really kind of help the active part of labor, kind of like the 5 to 7 centimeters of labor, the dilation there. But the issue is that if she's got opioids in her system and she delivers rapidly after that, it can cause neonatal respiratory suppression. I hope that you remember this from when you guys were in pharm, that opioids can cause respiratory depression. And it's the same thing with on neonates, okay? So always have your Narcan close by. It's best if you're going to give IV narcotics to give them during a contraction because that helps minimize the fetal effect because everything you give to the mom goes directly into their bloodstream and crosses the placenta and goes right to the baby. Also, somebody can have an epidural when they're in labor. Basically, an epidural is short-term analgesia that's introduced into the epidural space. So regional blocks are basically a local anesthetic that's introduced in specific parts of the body to help numb the area. So regional blocks are things like a pudendal, an epidural, a spinal, or a paracervical block. All right, so that's kind of what we're looking at here. This basically just shows you what's happening is they're putting lidocaine, so local anesthetic, and they're blocking these nerves here, okay? So a pudendal, actually, this was really common when I was born in the 70s. It's not as common now. It might, I mean, everything kind of comes around again, but right this moment, it isn't as common as it was. But what they're doing is they're putting this local anesthetic into the pudendal nerve, and it numbs it so you don't feel the localized pain at the perineum. So I'm very bummed because I have a super cool epidural video that didn't translate into my app that I'm using to record my videos. So what I'm going to do is post it on Blackboard. I want you guys to watch it if you're curious how epidurals work. It was the best one I could find. An epidural anesthesia is a local anesthesia that goes into the epidural space. So again, this is not going throughout her bloodstream. It stays in the epidural space only. Inside your epidural space is just nerves. So it keeps the area from the place of insertion down numb. Does not go to the baby, does not cross the placenta. The biggest issue we have with epidurals is maternal hypotension. So how we avoid that is we're going to give her an IV fluid bolus, typically about 500 milliliters before they place this epidural. Here we talk about a spinal block. Typically we use a spinal for C-sections because it's a faster acting than an epidural. An epidural takes a good 30 minutes to get full effect. It can be a little bit patchy sometimes, so that's kind of tough when you're doing surgery. But for a spinal anesthesia, they use that for a C-section almost all of the time. So it still is a local anesthetic, but it's into the spinal space instead of the epidural space. And you're numb from your nipples down to your feet. So a little bit different than than epidural. An epidural is typically from the belly button or the umbilicus down to about mid-thigh. I'm hoping that when you're doing your rotation with us, you'll get to see both of these procedures done. If your client is having a C-section and it's an emergency C-section and they have to use general anesthesia, you might get to participate in something I'm going to teach you about called cricoid pressure. But general anesthesia is not typically used because the gases that we use and the meds that we use cross the placenta and go straight to the baby. So it's not ideal. Typically we only use general anesthesia in an emergency situation, or if there's some contraindication to where she cannot get an epidural or a spinal. Maybe she has some complicated back trauma. I don't even know, but it's hardly ever done anymore because we know it goes right to the baby. Let's see. Yes, so I wrote that here. The fetus is at risk for receiving the anesthetic if the procedure takes too long. So there's something that we do as nurses. We typically don't do general anesthesia. It's not kind of something we help do, but what we can do is something called cricoid pressure. So you might see your nurses do this. What they're going to do is at the time that the anesthesiologist is intubating your patient, the nurse will apply cricoid pressure to the cricoid cartilage which includes the esophagus. And by including the esophagus, you prevent aspiration of the gastric contents. So you're going to use your thumb and your pointer finger, just like this picture says, and you're going to find the cricoid cartilage, and you're just going to push. You don't push hard. Push and kind of squeeze, pinch a little bit. And then it's interesting because you'll feel when they put the tube in it, you can feel it pass by your fingers. And then the anesthesiologist will tell you, okay, you can let go. And then you're done. So that's what cricoid pressure is. So now we are at the third stage of labor. So we've gone, her cervix is completely dilated, that's stage 1. Now, and then she's pushed the baby out, that's stage 2. And now in stage 3, the baby is out, but the placenta is still inside, and we're waiting for that placenta to be delivered. Please forgive my very loud dog, I'm so sorry. So this can take up to 20 to 30 minutes, this third stage of labor. So we're always going to ensure safety of our client and the new baby. Oftentimes the client will be holding the baby as long as the baby is stable and the client is stable. So safety first, and then we can facilitate the bonding of that little family there. We want to watch for signs that the placenta is separating from the side of the uterus. Those signs are a gush of blood from the vagina, because as the placenta is kind of stuck to the side of the uterus. Think of a scab on your knee when you were a little kid, hopefully as a little kid and not right now, but it happens. So if you have a scab on your knee, that scab is stuck to your knee. So think of a scab. So if you have a pregnant uterus and the placenta is stuck to the side of the uterus, the baby's already out, but the placenta needs to come out. We don't go in and grab it, and we don't pull it. We have to wait for it to come off by itself. So it peels off the side of the uterus, and when it does that peeling off, it releases a little bit of blood, okay? And the umbilical cord, which is hanging out of her body, becomes a little bit longer and lengthens as that placenta comes into the lower part of the uterus, getting ready to be delivered. It's important that we don't pull on we don't deliver babies, but the delivering person doesn't pull on the umbilical cord, okay? Let the placenta come all by itself. We need to monitor for and prevent excessive bleeding. Oftentimes, we will deliver Pitocin at this time. Pitocin helps the uterus contract, and it helps that placenta to deliver and keep that bleeding down to a minimum. The expected estimated blood loss for a vaginal delivery, sorry about the typo there, is for a vaginal delivery is less than 500 milliliters, and for C-section is less than 1,000 milliliters. So if you're going to have more than this, we might have a hemorrhage happening. So you want to be mindful of how much bleeding your client is having. Once the placenta is out, make sure we inspect it for any kind of abnormalities. Make sure that all the lobes of the placenta is there. If there's any remnants of the placenta or the membranes left inside her body, it will lead to a postpartum hemorrhage. So you want to make sure that everything is there. As soon as the placenta is delivered, we will begin fundal massage. The fundus is the top of the uterus. Now remember, before she delivered, the fundus was way up by her sternum. Well, now, since she delivered, the fundus is down by the umbilicus. And remember I told you earlier, the uterus is just a muscle. So now we have this uterus, this muscle that needs to be firm all the time to prevent a postpartum hemorrhage. How you can keep that muscle firm is by rubbing it. You rub the fundus. So you're going to reach up and you're going to rub the fundus, and you should feel it become hard like a table. And so you want to make sure that you educate your client to massage her own fundus. She can do that. It's not hard for her to do. If your placenta does not deliver within 30 minutes after the baby is born, she has a retained placenta. And what happens then is that she will have to sign consents for the placenta to go in and become removed by her healthcare provider. When that happens, they take her back to the C-section room. If she has her epidural still in, they're going to give her a nice big, almost like a surgical dose of anesthesia for her epidural. So then they'll reach inside her body and grab the placenta. If she does not have an epidural in place, they're going to give her like some medication through her IV to kind of put her like in a twilight sleep. And once she's asleep, they'll go in and they're going to put their hand inside the vagina up into the uterus and grab the placenta. And here we are now at the last slide, which is the fourth stage of labor. The fourth stage of labor is our immediate recovery of our dyad, which is our client and their new baby. This is the recovery stage here. Again, sorry about my dog. So we always must ensure that our dyad is safe at all times. Once we know that the client and the baby is safe, we can facilitate bonding. If the client wants to breastfeed, we can help them with that. We must always monitor INO. We want to make sure that the client is voiding, because if your bladder is full, it can displace the uterus, and a displaced uterus can lead to postpartum hemorrhage. So you have to kind of think about that too. This is how often you're going to monitor their vital signs after having a baby. We're doing vital signs, fundal check, and lochial checks every 15 minutes times 4, and then according to your policy. The lochia I'm talking about, that's the vaginal bleeding that happens after having a baby. The term for that is lochia. If we're concerned that your client is bleeding more than she should, we can weigh their pads to make sure that there's not excessive bleeding happening. And they're also going to give oxytocin to prevent a postpartum hemorrhage. And oxytocin will make that uterus contract, and that's how it works. Watch for signs of infection, assess and treat your pain, and educate your client and their family. Today we're going to talk about the labor and delivery process. We begin this content with actually talking about language and how we can use inclusive language to support all of our patients and their families. I'm not going to read this to you, but basically what it says in a nutshell, and I do encourage you to read it, it talks about not that we recognize as healthcare providers, especially in this world, that not all people who become pregnant and give birth identify as mothers or women. So I will try to use inclusive language, and I'm on that journey right now, and I think we all should be as nurses. The term family is used to describe anybody around your patient who is their support people. This slide, although it's very pretty, there's so much information on it. We're going to go through each different section here, okay? So this slide here talks about the stages of labor. There's the first stage of labor, second, third, and fourth. And honestly, this stage, is my pen going to work? No, not yet. Hold on, let me make my pen work here. This fourth stage here, everybody's already delivered. The baby's delivered, the placenta's delivered. This fourth stage is the recovery. All right. So let's go ahead and talk about the first stage of labor. So the first stage of labor is actually the stage where your cervix dilates. I called it the dilating stage. Again, just trying to make this not so foreign for you. So this dilating stage, a lot happens in this stage. The dilating stage, there's two phases of the dilating stage, and I know it can be kind of confusing because we have the stages and phases, and I apologize for that, but regardless, we have to keep moving here. So there are two phases of this first stage of labor, which again is the dilating stage of labor. We have this early phase of the first stage and this active phase of the first stage. So up here in this little columns here, I like this blue. I wanted to make sure that I was very clear that people will progress through the different stages and phases depending on if they're primes or multiples. Okay, so just kind of as a general rule, once you've had a baby, your body remembers what to do every time it goes through the laboring process, which is nice. The first time you have a baby, I would say almost all the time, there's going to be some rare instances when it doesn't happen. But the first time somebody's having their baby, it's usually the longest time. Remember, there's a human that's coming out of a very small spot, so the bones are tight, the pelvis is tight, all the muscles are tight, and the pregnant person and the baby work together to get everything loosened up to get that baby coming down and being delivered. So it takes longer. So if you're looking, we're going to talk about this early phase. Okay, let's talk about that first. So in your early phase here on this stage of labor, On your primes, it can last up to 6 hours, and on your multips, it can last up to 4. So you can see it's quite a bit less on your multips, all right? All right, so let's talk about this early phase here. So let's look at our cervical dilation. Now, I know we haven't taught you that too much about that, but your cervical dilation is early. Now, our goal, of course, is 10, so we're getting halfway through the cervical dilation in this early phase of labor. Their cervix goes from closed, which is 0% or 0 centimeters, to 5 centimeters, all right? The contractions are still irregular, all right? And what happens in this early phase of labor, the body is really getting going on labor. So the contractions typically are not as strong, and they're not as regular in this first phase. Now, as we get farther and farther in this first phase of labor, the contractions certainly becomes closer together and more painful. All right? And pain, let's talk about pain. I want to pause here and say that everybody manifests pain differently. You're going to, and you've met people in your practice that some people, things that you look here like, wow, isn't that hurting? And other people are really uncomfortable. And for you, it's like, that really shouldn't hurt so much. So pain is what your patient says. All right. So what I want to say is, as we progress through this first stage of labor, let's talk about this box here. What begins over here, our contractions begin mild and irregular and progress to regular, ultimately bringing us at every 2 to 3 minutes, all right? Our pain starts mild and progresses to severe by the end of this stage here. All right, so the early phase, like I said, it's about your cervical dilation. Once your cervix is dilated between 6 and 10, you've now entered into the active phase of this first stage. And up on the top here, it tells you for your primes, this active phase can last 3 hours. On your multips, it can last for 2 hours. So in this active phase here, your cervix, you have advancing cervical dilation. So your dilation is what tells you which phase you're in, which makes sense because this is the dilating stage, right, of this stages of labor here. All right, so let's talk about pain management. Now, I know that was on your home lecture, but depending on, how do I say, it's going to be on a case-by-case basis. So I've had students that will say, well, when can somebody get an epidural? That's going to depend on your anesthesiologist, but a lot of them will say, as long as you can sit still, I can go ahead and give you an epidural. So it used to be years and years and years ago, it was very regimented. If somebody was only 3 centimeters, they couldn't get an epidural. But what if that person who's 3 centimeters is really uncomfortable? So now, thankfully, we basically go on what the patients are telling us. Now, remember, when somebody has an epidural, they're not getting out of bed after that, right? So you don't want to give somebody an epidural when their cervix is 1 or when their cervix is closed, because they still got a long way to go to get to 10, and have them in bed that long might be kind of unfortunate. So I will tell you, it's on a case-by-case basis. You're looking at the G's and P's here on your patients. You're looking at the cervical dilation and how they're manifesting their pain, okay? All right. So I'm going to change colors just because it's fun. All right, so now we're at 10 centimeters. So once you're at 10 centimeters, you're going now into the second stage of labor. And in the second stage of labor, I like to call it the pushing stage. So finally, your patient's like, I can finally do something, and pushing is what they can do. This also can be separated here, and I'm gonna teach you about these two separations. I have it separated into 2 phases, similarly to that first stage there. And again, this is your time frame with your primes versus your multips. So your latent phase of this second stage of labor is with somebody who has an epidural. Now remember, and we talk about this in the home lecture, when somebody has an epidural, they pretty much can't feel the pain sensations from wherever that epidural is inserted down to their toes, okay? If you were to take your finger and push on their leg, they would feel the pressure, but if you took something pokey and sharp and poked their leg with it, they would not feel the sharpness of it. So when somebody has a well-functioning epidural, they don't feel the pain from their contractions, all right? So if somebody, remember, all of our patients in this stage are 10 centimeters. We already talked about that. So our patient with an epidural, we've established they're 10 centimeters dilated. and they have a well-functioning epidural. So we are going to go down this side here. We call it the laboring down or passive descent in the latent phase. Basically what that means is we're going to allow the person's uterus, the strength behind that huge muscle, to push the baby down. All right. And when I get to the end of both of these, that'll make more sense. So when somebody is laboring down, when we have a well-functioning epidural and a nice category 1 tracing, we put them on their side, we let them rest, and the baby, the uterus is going to contract and rest, contract and rest. And when it contracts, the patient's not pushing, but the muscle's pushing. And the muscle's pushing the baby out towards the opening. All right, that's somebody with an epidural. Somebody without an epidural is going, I'm going to switch colors because I want to. We'll pick green. Somebody without an epidural is going to be in this active pushing phase of the second stage of labor. Without an epidural, you can't help but push. It is overwhelming. For you to tell your patient don't push, they can't help it. So when somebody has an epidural, their uterus pushes the baby closer to the opening to be born. Without an epidural, the patient's going to do all of that active pushing. That's why it's called active pushing, okay, as opposed to resting. All right. So we're going here with no epidural. Everybody in this stage is 10 centimeters. We already talked about that. And now your patient's pushing and pushing and pushing and pushing and pushing and pushing and pushing to get this baby to descend until it gets close to delivery, okay? So your primes can push up to 3.5 hours. As long as we're having as long as our station is changing and the baby is coming down. I'm going to teach you about station in a little bit. We're going to let that person push and push and push. They're going to push on their side. They can push on all fours. They can use a squatting bar. As long as that baby's moving, we don't care. And as long as we have a nice category 1 tracing. All right. So I want to kind of change really quick before I go on to the third stage. I'm going to use black. So now, regardless of whether the uterus is pushing for the latent phase or the patient is pushing for the active phase, ultimately, both of these phases here lead to fetal rotation and descent. You see that here where this black arrow is? Okay, so here we go. So now this baby has descended. Now, somebody who is actively pushing is just going to keep pushing till the baby is delivered. That's it. We keep pushing and pushing and pushing. Remember, this person over here is not pushing, right? The uterus is doing all of the work. Once the baby gets low enough into the pelvis, the back of the baby's head starts hitting the muscles at the patient's butt. Okay? And they're going to put their call light on and they're going to say, something's different. They don't feel that pain in their belly, right? Because the epidural is blocking the pain. What they feel is the pressure. They're going to put their call light on and they're going to say something's different. I don't know what. Something's different. They might say they have to poop. They might just say they feel pressure. All of that is because the fetus's head is hitting all of those muscles. So then what you're going to do is you're going to assess the progress of this laboring down. So you're going to do a vaginal exam. Okay, so you're going to do a vaginal exam and you're going to see if the baby is low enough to start pushing. Remember, this one hasn't been pushing yet over here. So we start pushing when the baby's about a +2, again, depending off their prime or multips. So by the time you get down here, everybody's pushing. And ultimately, the baby comes out, okay? And there's your smiley face there. And thus, that leads us now into the third stage of labor. So on your third stage of labor, the baby is out, but the placenta is still inside, okay? So I want to teach you and talk about if it's best case scenario, right? Best case scenario, baby comes out, it's crying, everybody's doing well, baby goes right on the parent's chest. We start making it, we start drying it off, getting the amniotic fluid off of the baby, stimulating it to cry while we wait for the delivery of the placenta, all right? So the delivery of the placenta is still inside, and at some point in this stage, the umbilical cord is cut, so the baby is not attached to the placenta anymore. And then we wait, all right? And delivery of the placenta can take up to 20 minutes. And after that, if it doesn't come out, it's called a retained placenta. And I'll talk about that in a second. So as the delivering person, which in the program you are in currently, that is not going to allow you to deliver babies. I will tell you that we've delivered lots of babies come when they want to, but for the sake of conversation right now, I'm going to talk about the person delivering the baby, the healthcare provider, the nurse practitioner, whoever that would be. So we're waiting for the placenta to come. There are signs that this placenta is detaching, and it's facilitated through the contractions. Now, these not these whopping labor contractions, they're less painful. So as this person contracts, it starts to, I would say, push the placenta off the side of the uterus. And as somebody who is watching for the placenta to come, I will know the placenta is getting ready to be delivered because my umbilical cord that's now hanging out of this person's body is going to start lengthening. And as the placenta pulls away from the side of the uterus, the patient starts to have some vag bleeding, okay? Because now that where the placenta was attached is open and the blood is dripping, okay? So once we look at that, we deliver the placenta into the bucket, okay? And we look at the placenta to make sure all the parts are there. Well, what happens if we get down to this 20 to 30 minutes later and the placenta is not delivered? Then we have what is called a retained placenta. Anything that gets left retained in a person's body after having a baby can lead to a postpartum hemorrhage. So certainly a placenta that is retained can lead to a postpartum hemorrhage. So what they will do is consent the person for surgery. They will take them to surgery and they will give them some medication to either give them like a twilight sleep maybe and go in vaginally and get the placenta. It doesn't usually work if they try to get the placenta when the patient has no pain medication on board because it hurts them. Now, if their epidural is still functioning, they can turn the epidural up and they won't feel that. So you might see the variance of that, but that is a retained placenta. All right, let's move on to the fourth stage. So at the end here, the placenta is delivered. So now we've got both the baby and the placenta delivered. And now we are in the fourth stage. So I want to pause and kind of go back to the delivery. As long as staffing is appropriate, in the best case scenario, you've got a team for the baby and a team for the delivering person. If you're having two babies, you've got a team for each baby and one team for the delivering person. So we're going to say for this conversation, we're only having one baby. So I've got a nurse who's there to be that baby nurse, and I've still got my team that's taking care of the delivering person as well. All right, so now we're in this fourth stage of labor. So if I'm in charge of the baby and you are in charge of delivering person, I am now in charge of making sure the baby is stable. Is it safe? What are my vitals? Okay, how's the circulation? The person in charge, the healthcare team in charge of the delivering person is going to be assessing the vitals of that person and assessing their vag bleeding, making sure we don't have an immediate hemorrhage happening there. Once both parties are deemed stable, right, because they're both independent human patients, once they're both seem stable, I, as the baby nurse, am going to hand off this newborn to the labor nurse. And now the labor is going to finish the recovery on the baby and the person who just delivered, and they will go to postpartum together as a unit or a dyad, couplet, pick whatever word you like better, once everybody is stable. Okay? Your recovery stage can last up to 2 hours depending on what went on with the patient. Did they have a C-section? Did they have an epidural? Or did they not have an epidural? So the timing can vary there, but usually it lasts up to 2 hours. All right, for the next little bit here, we're going to talk about the 5 P's of labor. Now, what are the 5 P's of labor, you might be wondering? Well, these are these 5 factors that influence the success of having a vaginal delivery. That's what we're talking about right now. We will cover C-sections in just a little bit. All right, so what are the 5 P's? We have the passenger, and the passenger is the fetus and the placenta. So it's both of that, right? Because everything has to come out. The passage, which is that birth canal. The powers are the contractions, the position of your patient, and the psychological response. All right, let's talk about the passenger. The passenger has a lot going on with it. Now, again, people have been having babies since the beginning of time. I understand that, but these are identified factors that will help things go a little smoother. So let's first talk about the presentation of our passenger. So basically, the presentation is the part of the fetus that's entering the pelvis first. Ideally, in a perfect world, it is the back of the head, which is the occiput. All right. Now, babies sometimes can come chin first or shoulder first or breech, which is butt first or feet first, right? But in a perfect world, babies come out head first. That's how they fit. Anything else, they're probably going to have a C-section. All right, now let's talk about the fetal lie. So your fetal lie starts in the second section, which is kind of hidden for me. So fetal lie is the relationship of the client's the spine to the fetal spine. Basically, do the spines line up is what basically all those fancy words mean. In a perfect world, the fetus's spine and the client's spine are exactly lined up. That is called a longitudinal lie, okay? That where the spines line up, as opposed to a transverse lie, which means the baby's laying like this and the spine is like this. Okay, so that's a transverse lie. So transverse lie, we're having a C-section. All right. Now, longitudinal lie, assuming it's cephalic, right? Because you can have a longitudinal lie be cephalic or breech. A breech has a C-section, but both of those have the spine lining up, right, with the patient's spine. But we have to be head down to not have a C-section. The next thing is the fetal attitude, which talks about this stuff here. Basically, what the attitude is relationship of the baby's body parts to each other. So the fetal position, you all heard of that before, right? That's been around since the beginning of the planet. The fetal position is when the chin is completely flexed to the chest. That's this. This is the fetal position. This is the most conducive for a vaginal delivery. And you can be extended, which means the chin is away from the chest. And that's what you're seeing here. And there's varying stages of extension there. And then the position, which is the relationship of the presenting part, okay, which is the occiput, right, the back of the head, in reference to the pelvic quadriceps. We're going to talk about that. So let's talk about complete flexion, which again is this fetal position, right? We already talked about that. This baby is all tucked in, chin to chest. The knees are up, all right? And this position here allows the smallest part of the baby's head to present into the pelvis. That's good. All right. So I'm hoping as we go through this, you're asking yourself, well, how would I know? How would me as the nurse know what position the baby is in? I've asked students this and they'll say, oh, we get an ultrasound. That's true. You can do that. But what's quicker? I'm hoping you're thinking a vaginal exam, because if I'm going to go in here and do a vaginal exam, what I'm feeling for are fontanelles of the baby. Now remember, your anterior fontanelle is the big one, the big diamond, and that's right in the front of the head. Your posterior fontanelle, of course, is behind that. It's towards the back of the head. The posterior fontanelle is hard to palpate. So if I'm doing a vaginal exam on my patient, and I'm going in here, and again, when you do a vaginal exam, it's just 2 fingers, not putting anything more than that in there. So we're putting our 2 fingers in, and we're going all the way in until we stop. And we're going to stop at the baby's head. And then I want you to feel, now you guys aren't going to be doing vaginal exams in this class, but what the nurse is doing is feeling around for sutures of the baby's head and for fontanelles. That helps me as a labor nurse decide which way this baby is facing. So let's separate this slide here. Let's talk about this, a compound presentation. So what happens, this baby, if you look at it, it's still head down, but look, we've got a hand here. So when I'm going in here and doing a vaginal exam, what do you think I'm feeling? I'm not feeling fontanelles or sutures. I'm feeling the backs of this baby's fingers. Now remember, we're going to talk about cervical dilation in just a little bit, but if your patient's only dilated to 2 centimeters, that's not very big, right? And so you really can't feel too much. And if you pick this up at an 8 centimeter cervix, you really can feel more. You may be thinking to yourself, well, can't you just push the baby's hand out of the way? You can try, but babies really get comfy and get tucked in. It's pretty unusual to be able to push the hand away, but a lot of the patients will ask the healthcare provider, hey, can you just try to push the baby's hand out of the way? We can try, but most of the time it's not successful. People with a compound presentation often have a C-section. Because again, also, if this hand is in the way of the head, the baby's station is not coming down either, too, when we get to the station. So a compound presentation prevents the baby's descent into the pelvis. A Sinciput presentation. Now again, I want you to think about you or me as the labor nurse. Okay, this baby, yes, this baby is still head down. Yes, this baby is still head down. We all agree. But there's no flexion of the chin and there's no extension. This baby, if it were standing straight up, is looking directly in front of it. Okay, so in me as a labor nurse, how do I know? I put my glove on. I put my 2 fingers in to do pelvic exam, and I went right into the anterior fontanelle. I should not be feeling the anterior fontanelle, right? Because I should be feeling the back of the baby's head, which is there. This patient as well is having a C-section. So now let's talk about the brow presentation. Now again, this is a pretty self-explanatory. Both of these patients are having a C-section on this screen. So your brow presentation, now remember your fetal position, right? This baby's head is not fully extended because that's here, but it's almost. How will I know? All by vag exam. That's how I'm going to assess all of this here, right? That's my assessment on this piece. When I go in and I do check this person, I'm not going to feel any sutures and I'm not going to feel any fontanelles because I'm kind of running into the forehead here. There's nothing, if you feel your forehead, you have nothing there except forehead, right? You should, when you check a patient with whose baby is in the right position, you may not feel fontanelles because the posterior fontanelle is teeny tiny, but you should feel sutures. On this patient and this patient, you're not going to feel sutures or fontanelles, okay? On this baby over here, instead, I want you to stop and think about it. I want you to reach up and feel your forehead. It just feels like bone, okay? Over here, when you have a face presentation, now I want you to reach up and I want you to just lightly palpate your eyes please close them, or your nose or your lips. That's what I feel when I do an assessment, a vaginal exam on my patient who has baby is a face presentation. I don't feel the bones. I feel squishy things. I feel cheeks. Especially the baby's like a chubby baby. I feel cheeks, I feel a nose, I feel the eyes. The baby, if you touch the mouth long enough, will start sucking on your finger, which can be startling when you're doing a vaginal exam, okay? So it's all about your assessment. So you may not know what you feel, but you know it's not in the right position. And at that point, grab a friend to do a vaginal exam or call your healthcare provider and give a nice S-bar, which is why your S-bars are part of your clinical assignments. And then your recommendation would be an ultrasound. All right, we're still talking about our fetus, and all of these fetuses are in the wrong position, right? Nobody is head down. They're all a mess. They get confused. Let's first talk about the frank breech. Nope, I lied. I want to talk about complete breech first. Now, remember the fetal position with the chin tucked to the chest? This is basically the baby's in the fetal position, but it's upside down. Would you agree? Okay, so this baby is delivering, all these babies are having a C-section. Okay, I already said that. Here, your frank breech. The baby is still butt first. It's still breech, but it's not in the fetal position. The toes are up by the forehead. And your footling breech, you can have a single footling breech or a double footling breech. That's what you have there, okay? And then here, this is called a transverse lie. So when I go in and I do a vaginal exam on either one of these two babies here, it's probably going to feel bony. Or it depends how skinny the baby is. If baby's coming hips first and I run into the hip bone, it's going to be bony. Not going to be sutures. Not going to be a fontanelle. Here, I'm going to run into the legs. Here, when I do a vag exam here, I run into nothing. There's nothing coming into the vaginal area, right? Baby's all inside the uterus. All right, so again, I might have one of my friends double check my patient, and then I'm going to call my healthcare provider, give a really good S-bar, and my recommendation would be, if you were in class, I would have you raise your hands. Your recommendation would be an ultrasound. That will give us our diagnostics to ensure that the baby is in fact in the wrong position. We're going to talk about turning babies. I'm using quotes, you can't see me, today in this lecture too. But for right now, this is what this definition is here. I'm going to talk about, by the end of the day, something called an umbilical cord prolapse, okay? And I will tell you, every baby on this slide, they're in the wrong position, all right? When a baby is in the right position, when it's head down and it's nice and flexed. I want you to think of the head of the baby acting like a cork into the pelvis. As it comes through the cervix, that head of that baby is a nice tight fit, and in it comes, okay? So when somebody's water bag breaks, whether it is spontaneously broken or it artificially broken, we talk about that today too in our time together. But there's a risk if the baby's head is not well applied to this cervix, there's a risk that the umbilical cord can come out. And that's called an umbilical cord prolapse. I have a whole slide on it, so keep your questions. Not that you can ask me because I'm recording this, but I will answer your questions, okay? Now, when somebody has an umbilical cord prolapse, that's a fetal emergency. Babies can die within minutes here. So I will tell you all of these, 1, 2, 3, all 4 of these. If the baby is in this position, and certainly this one and this one are the highest risk of an umbilical cord prolapse because there is nothing acting as a cork to cork up the opening, okay? On these two here, yeah, it's risky because it's not a head, but the butt might be able to kind of cork up that opening. But certainly with your footling breech, double, single footling breech, as well as your transverse lie here, and even your oblique lie, OBL, I got to put a picture. Oblique lie, which is a shoulder lie. Baby's coming down shoulder first. That also, there's a risk of an umbilical cord prolapse here with that. So here on this slide, we're going to talk about fetal position, just like it says there. How do I determine fetal position? So I've already kind of told you as a labor nurse, yes, of course, I can get an ultrasound, but that's costly, right? It's much more efficient to at least get an initial assessment based on a vaginal exam. And how I do that is by feeling sutures and fontanelles of the baby. I've told you that like 3 times. Over here, this side and this side, this is just anatomy class, okay? This is just a refresher for you so you can remember what's what. Okay, let's go to the middle because it gets kind of confusing. So if we're going to determine the position of the baby, we do this by measuring the back of the baby's head in relation to the mom's pelvis. And that can get kind of confusing. Let me go through it, and I think you'll understand it. This right here is the pelvis. Yeah, you got that. You're all smart. So I would say here and here, ROA and LOA, are the smoothest position for the baby to deliver vaginally, okay? It's kind of meant to go that way. So let's talk about ROA here. Now remember your fontanelles, we've talked about that. The front is the anterior, and that's the bigger one. The back is the posterior, and that's the smaller one. And the occiput is the back of the baby's head. So what we're measuring is where's the back of the baby's head in relation to the mom's pelvis. So let's talk about this. Right occiput anterior. So here, this is right here. This is the patient's right and left. Remember, this is the part that can get confusing. And where's the back of the baby's head? Where's the occiput? Here. So this baby's in the right occiput anterior. The occiput is facing this way, anterior. This baby is in the left occiput anterior. This one, left, so we've got right and left, right? So we have LOT, left occiput transverse. So left occiput's the baby's head and is directly facing this way. And this one here is a posterior baby, these two. So basically, it means that when you're checking your patient, the back of the baby's head is facing the posterior side of the person's pelvis, left and right, okay? That's how we do that. Though this slide talks about something called Leopold's maneuvers. I will say I would love you to do these when you're in clinical. I would love it. I would love it. I would love it. Most of your labor nurses are pretty decent at the first 3 maneuvers, all right? I was labor nurse for going on 30 years, and most of us really aren't good here at this one. So don't worry about that one. You might not see your labor nurses doing this. That doesn't mean they're still good nurses. They just don't do this. I encourage you to do this with your own faculty. All right, the first 3 maneuvers, what I want you to do, and just like this picture show, you're not exposing your patient's whole body. Just expose the area that you are going to assess. You don't need gloves unless there's somebody in isolation or there's bloody skin, I guess, which is a different conversation, hopefully, on the patient's belly. So we're assuming everybody's skin is intact, right? Nobody's in isolation. You're going to walk in the room, you're going to wash your hands, and you're going to tell your patient, I'm going to assess the position of the baby. And they're going to say, okay, because they don't really know what that means anyway, and that's fine. So you're going to just expose their tummy, and I want you to stand kind of where their knees are. So you're standing facing your patient, right? And what I want you to do is I want you to take your hands and I want you to reach on either side of your patient, like this says here, and I want you to kind of have your fingers join at the fundus, and I want you to push right very lightly. Don't do this during a contraction, by the way. And I want you to palpate with your fingers, what are you feeling in the fundus? Is it hard or is it soft? The hardness would be a head. The softness would be a butt. So that's your first step. What are you feeling in the fundus? So here, the second maneuver, your hands are here. We already talked about that. And now I want you to bring both of your hands down the side of this patient's tummy on both sides. The back is going to be smooth. And then on the opposite side, it's going to be a little bit lumpy here. And that's where the hands and feet go. So if you're in the second maneuver, I'm going to pause a second. So now we're going to the third maneuver. So now just take your left hand away, or your non-dominant hand, right? Because your other hand's right here, and I want you to bring your hand, and you can rest up above your wrist, like this person's doing, just rest it on their skin. And then you're going to make a C with your thumb and your pointer finger, or your thumb and your middle finger. And you're going to put your thumb and that finger, or whatever one you want to use, around the baby's head. And all you're doing is giving it a little wiggle. You're testing for engagement, okay? Before I go on to the fourth maneuver, I want to pause for a second and say, if you have established by your palpation that the back is over here, which we already have, you're going to take your Doppler and you're going to put it on the baby's back. Now, what if the baby is breech? If your baby is breech, because in step 1, you've established that it's a hard head up there, you're going to get heart tones in the upper quadrant. So where you're going to get heart tones depends on where that part of the baby is, right? All right, so then let's go on to this fourth maneuver. So now look, this person's hands are coming this way. So now you, as the nurse, you're now moving from down here where you were standing to up here. And you're going to take your hands and you're going to come down on either side of your patient. This hand, that's just the back of the baby. You're not going to feel much here. This hand, what you're feeling to make sure the baby is it flexed or is it extended? That's really hard to do because babies don't like it when you do this. And it depends on if your mom is overweight. Is there lots of fat there between the muscle of the uterus and the skin? So this one's a little bit harder. So if you don't do this, I'm not going to be that upset about it. But I would like you to do the first 3 maneuvers with your faculty when you're in clinical. All right, this next slide talks about the cardinal movements of the passenger. Remember, your passenger is your fetus. All right, and so there's 7 cardinal movements. And if you're looking online, lots of students like to get extra help going on YouTube. You don't have to do that. I have already put videos in your Canvas course that those are the videos that I have seen, and they actually are true. I can't control all the videos that are out there. So these are the 7. These are the 7 cardinal movements of your passenger, which is your baby. They must happen in order. They can't happen out of order. If they happen out of order, they don't happen at all, there's a high risk of having a C-section. We talk about engagement in just a second. But I want you to look at here. So steps 1 through 4 are done without you even seeing it. They're done inside the patient, okay? So engagement, number 1, that's when the presenting part of the baby is at 0 station. Put a pin in that. We're going to get there. And then this uterus is contracting, or the patient is pushing, either one, and this pushing that baby down through the pelvis. Descent is your number 2. Number 3, when the baby's head hits that cervix, it flexes and it automatically, ideally, puts that baby into the chin to the chest, which is the right position, your fetal position. After that, number 4, and sometimes, no, I lied. Number 4, internal rotation. Again, we're not seeing this. This is all happening before the baby's head is delivered. All right, so your occiput's going to rotate a little bit to the left there, and then the baby's head is going to pass under the pubic bone, like a little tuck and roll, okay? And then the head is delivered. And then we're going to pause just for a second, restitution. After the head is born, a tiny pause, and then it rotates into the position it was when it first came in to the pelvis. The shoulder comes out, and then the rest of the baby is born. All right, that was our passenger. Let's talk about our passage. Our passage is just are the bones, okay? The birth canal, which is the pelvis, the cervix, the pelvic floor, the vagina, and the introitus, which is the opening there. So that's all the passage. Basically, here, these are the pictures of what these are. We can all have a different kind of pelvis, but the one that has the best chance of having a successful vaginal delivery is the gynecoid pelvis. All right, we have made it to the cervical. We have made it to the cervical dilation slide that goes with this. When you are in clinical orientation, you're going to talk about this on your labor station. There's tools that you can use to help us when we're learning how to do this. Again, the expectation is that you are not doing vaginal exams during OB clinical rotation. Now, if any of you choose to precept, you might get an opportunity at that point. And then if you work in labor and delivery, you're for sure going to be able to do it and learn how to do it correctly. But you don't have enough days in clinical to be able to kind of dial this down. What I really want you to do is to understand what it means when your nurse says they're 5 centimeters dilated. We are very visual people. And there's tons of visuals on like Pinterest and all kinds of fun things. But I like this one. I've used this one a long time. Your cervix. Now, again, it depends. I've got very, very tiny hands. If you look at your hands, and my wedding ring is a size 4, okay? So if you look at your hands and your hands are a little bit bigger than mine, we might have some discrepancy whether the patient is 1 or 2. That's okay. That's going to happen, right? But we should not have a discrepancy whether they're 1 or 4, all right? This is how we measure cervical dilation. The next thing we're going to talk about is effacement. What effacement basically is the shortening or the shrinking, or pick a word you like better, of the cervix. I want you to stop and I want you to look at your hand. All right, put your hand in front of you and look at your middle finger. Do you see how long your middle finger is? If your patient was dilated 1 centimeter, so you could get your middle finger in their cervix. All right, I want you to use your imagination here. So a cervix that is 0% effaced, which is this first one, I want you to look at your finger. It's about as long as your middle finger, okay? Now remember, when a cervix is completely effaced, which is our goal here, it's about as long as the length. If you're wearing a t-shirt right now, I want you to go up and reach the sleeve of your t-shirt. Not a sweatshirt, that's too thick. It has to be a t-shirt. So our goal is to get from the length of your middle finger to the sleeve of your t-shirt. That's a lot of work that your body has to do, okay? So 0% efface, again, is about the length of that finger. And then if you were to look at your finger now again, so 50%, which is halfway through, I want you to think if you are putting your finger through somebody's cervix and you can fit half of your finger between, if at the top of your finger is the baby's head, and at the bottom of your finger, it would be like the labia, okay? So, that's kind of your anatomy there, right? The bottom of your cervix there. So if the top of your middle finger is hitting the baby's head, you're only able to get half of your finger through that cervix now because it is 50% effaced. When somebody is 100% effaced or completely effaced, depending on your nurse, okay, you're going to hear both. That means that the cervix, when you go ahead and check your patient, and again, the end of your finger is going to be the baby's head. So you find the baby's head, and you're going to open your 2 fingers to assess your dilation. That's the first thing you're going to assess. Then I want you to feel how much the length of that cervix is in relationship to your finger, and that will help you to establish, are they 50% effaced? Are they completely effaced? If they are completely effaced, the rim of that cervix feels just like a rubber band. And again, our goal is completely effaced or 100% effaced. Station. This is a hard one for my students because they get confused, and I get it. I'm just going to go with it, and the more we talk about it, you'll get it. We all get it, so you'll get it. Fetal station is the relationship of the baby's head to the mother's pelvis. So I want you to look at this picture. So here, let's start up here. So see the zero station here. So zero station is basically the skull of the fetus is directly in line with the ischial spines of the pelvis. Well, how do you know that? This is all done by a pelvic exam. So I want you to use your imagination again, since you're not going to be doing this in class. I already told you when you're doing a vaginal exam, you put 2 fingers in the person's body and go until you hit the baby's head or whatever's presenting. We're going with the head right now. And then you open your fingers until you can get your fingers, you establish your dilation, and then you're going to establish your effacement. And now we're going to do station. On the back of your middle finger, or, well, my middle finger is what I use, but you can use either one of the two. When you're palpating the ischial spines, it feels like a frozen pea. It's tiny. If you were to look back on an anatomy book, you would see that the ischial spines are tiny. So what it feels like is, I could feel it on the back of my finger, and I usually use my middle finger for that one. So I would feel the ischial spines, and then I would figure out how, either if the baby's head is right in alignment with that ischial spine, that's a zero station. Or is it higher than my ischial spine? Is there a gap between where I feel the ischial spine and the baby's head? Okay, then that's up here in the minuses. Or is the baby so low in the pelvis, I don't even feel the ischial spines? Okay, so that's the relationship for that. So now let's talk about this picture. Zero, when a baby is at a zero station, that means the baby is engaged. Engagement is good. Engagement, I want you to go back to when we first introduced the term cord prolapse, umbilical cord prolapse. If you have an engaged baby, which means the baby's head is at a zero station, which is the ischial spines, you cannot have an umbilical cord prolapse. So ideally, people's water bags don't break until the baby's at a zero station, all right? But sometimes people's water bag breaks all on its own. So if your baby is above a zero station and their water is broken, the patient's probably not going to be getting out of bed until the baby descends into the pelvis a little more. So up here, so again, if we're coming up this way, right, this is our vaginal exam. Our baby's at a zero station. That's good. We have an engaged baby. As it gets closer and closer to being born, it goes +1, +2, and +3. +3 is what we call crowning. Crowning. Which means that the baby, even when the person's not pushing, that the labia is parted and the baby's head is just sitting there like a crown. That's crowning. +2 means we're almost there. If somebody's going to use a vacuum to help with delivery, you at least want them at a +2, no higher. All right. All right. So now let's talk about the babies that are high. Okay. So we've got a zero station as engagement. So -1, -2, -3. This baby is going higher. This baby is higher in the pelvis than it should be. There's a bigger gap between the ischial spines where the baby's head is. And this gap is concerning because if we have a rupture, we could have an umbilical cord prolapse, okay? So a very high baby is a -3. And then as it gets lower and lower in the pelvis. And again, we measure this all by where the ischial spines are. So when you're in clinicals, they're going to tell you, okay, student, your patient in room 3, she's 350 and -2. So how you do cervical dilation for documentation, you write the dilation, then you make a line. And then you write effacement, and then you write station. Okay, it's always in that order. So if your nurse or you, in looking at the chart, establish your patient is 6, 90, and +1. That means they're 6 centimeters dilated, they're 90% effaced, and the baby's at a +1. So that's what that means, okay? All right, now we're on to the powers. I feel like I want to switch colors. We'll use green for the powers. So the powers. The powers is that big uterus, right? You've seen somebody who's walking around Target or the mall or whoever who's been pregnant with that big uterus, that 9-month uterus. That's a big muscle. It's a very powerful muscle. The muscles are, the contractions are the powers. The contractions of that uterus are on the powers. I want you to think about somebody who's pregnant, and we're going to assume the baby is head down. As the uterus contracts, that muscle's putting pressure on the baby and pushes that head against the cervix. Okay, and that's what causes that dilation. This is written here. Okay, we measure contractions in frequency, duration, and strength. I'm going to teach you about that in these next couple slides. When you guys go to clinical orientation, you're going to learn how to measure to establish fetal well-being as far as measuring their heart rate and the things that are associated with that. So we separate it so it's not as overwhelming for you. All right. Let's talk about terms that we use to assess uterine activity. I already kind of introduced them: frequency, duration, and strength. Frequency. How often your person is contracting. Okay? There's an app that will measure this, but you as a student need to know how to do this, okay? So we measure contractions from the beginning of one to the beginning of the next. And in that interval, we look at the shortest one and the longest one. I have some strips, I think, in the next slide or the next couple slides, and I'm going to show you how to measure contractions. So the frequency is how often they're coming. How frequent are these contractions coming? The duration is when they happen, how long are they lasting? Your frequency is measured in minutes. Your duration is measured in seconds. All right? And strength is how strong they are. Now, a couple of things. We talk about fetal monitoring a lot because there's always 2 patients in this class. Where like in a med-surg class, you have 1 patient per body. Well, now we have 2. So I don't want you to forget about that. We must have established fetal well-being all the time and maternal well-being all the time, okay? So how strong are the contractions can only be determined by palpation or by an IUPC, okay? IUPC is intrauterine pressure catheter. That actually measures the actual strength of the contractions. If you don't have an internal pressure catheter in that's picking up the strength, you're going to ask your patient on a scale of 1 to 10, what are your contractions like? And you're also going to palpate them. You are going to put your hands on that person's abdomen and you're going to feel it when it's not contracting, so it feels like your belly, nice and soft. And then as the contraction starts, don't tell them, hey, guess what, you're contracting, because they know, unless they have an epidural. You're just going to feel it. And as the contraction gets to the peak of the contraction, it's going to feel hard like a table. And then as that contraction goes away, it's going to get softer and softer. So your responsibility is to make sure that you have verified by palpation that their patient's not contracting. So there's a resting period in between your contractions, and then you're palpating the strength of your contractions as well as asking her, okay? Now, when she has an internal monitor in that picks up that picks up the contractions, called an IUPC, intrauterine pressure catheter, that will actually measure the strength for you. There are 2 types of monitors. There's external and there are internal. And both sets of monitors, always a set. You've got 1 piece of the monitoring system that picks up the baby's heart rate and 1 piece that picks up the contractions, okay? The piece of the monitor that picks up the contractions for the external monitor is called a tocodynamometer. We just call it a toco because nobody can say that clearly. So if you have an external monitor, the external monitors do not pick up strength, okay? The external monitors do not pick up strength. You must measure strength when your patient has an external monitor by palpation and asking them. If they have an internal monitor in, an IUPC, which goes inside the body, internal, right? That will measure the strength, but you must confirm by palpation. All right, that's enough for that one. Other definitions. I want to talk about tachysystole, which I should put down in the 3rd paragraph. Tachysystole is when the contractions are happening too frequent. Let's talk about contractions. I already said when somebody has a contraction, the pressure of that contraction pushes the baby towards the cervix. Contraction goes away, the baby recovers. Contraction starts again, it gets squeezed and squeezed and squeezed and squeezed. Contraction goes away, the baby recovers. Ideally, that recovery period, so the period in between contractions, is at least a minute. All right, because during that recovery phase of the contraction is when the baby recovers. That's why I keep saying that. All right. So if you don't have enough time in between your contractions, you're gonna have fetal compromise. When you don't have enough time between contractions because they are coming too frequently, it's called tachysystole, and we talk more about that as we keep going. All right. Relaxation time, and that's kind of what I kept saying, recovery, but relaxation time is the time in between the contractions when the baby recovers. All right. And then the resting tone. We already talked about that. You're going to palpate the resting tone always confirm with palpation, but if they have an external monitor on, you always palpate contractions and resting tone. With an internal monitor, that will pick up strength and resting tone. All right. So if you have somebody, we're still talking about strength here. So if you've got somebody who is on an external monitor, and when you see them at orientation, and at clinical, it'll make sense. The external monitor, the Toco, that picks up your contractions, it's not fancy, you guys. All it is a button. So it's only good as where you put it as the nurse. If you put it in the wrong spot, it's not going to show any contractions. Your Toco belongs on the fundus, which is the top of the uterus, okay? Because that's where the pacemaker of these contractions are then. So we want to make sure we're picking them up so we can pick up these contractions for them. Ideally, we have no more than 5 contractions in 10 minutes. When we do that, the term for that is called tachysystole, when we have more than 5 contractions in 2 minutes. And the problem is because there's no recovery time in between the contractions, so the baby can have fetal compromise. Understand that when somebody is in pain, their blood pressure is elevated, their heart rate's elevated, so we're not going to do their vitals when they're contracting. That's not okay. Okay, so this picture here just kind of shows you want to have ideally a minute in between your contractions, maybe a little bit longer. Okay, so how do we measure? And I already covered this. Confirm with palpation what the external Toco is, Toco dynamometer. We never can say that. This line here, affected by maternal habitus and proper placement. I already told you this. Maternal habitus is how overweight your patient is. Okay. External monitors, like I said, they're only going to pick up the contraction if they're in the right place. If your patient is really, really, really overweight, there's a big chunk of adipose tissue between the muscle of the uterus and the skin where this external monitor is resting. So the contractions, they may be contracting like gangbusters, but the force of that contraction gets absorbed into the fat. So it's not going to show, if you will, a big hill on the monitor, even though they might still be contracting. Quite the opposite. If you've got a patient who is teeny tiny with no adipose tissue between the muscle and the skin, they could be chatting and not feeling contractions at all, but they're showing off the Richter scale on the monitor. That's just because of it's an external monitor. Okay. Internal pressure catheter. Remember I told you that's called an IUPC. Anything internal is associated with risk, so we're only going to use them if we have to. I told you what tachysystole is. Hypertonus means that your contractions are lasting longer than 2 minutes. Ideally, your contractions last about 60 to 90 seconds. This is our goal. So when we've got a contractions that are lasting longer than 2 minutes, that baby's getting squeezed for a very long time, and there's a chance of having fetal compromise happen. Okay? Okay, so let's put this into practice here. Let's look at these strips. For today, we're not going to focus on the top. At the end, I'm going to tell you kind of like, I'm going to change colors. My tidbits for this. So let me just get my color change. I picked blue. Okay. Sorry. Okay. This white section here on your strip, you're going to have strips that you look at in orientation when you go. You're going to have strips when you're going to clinical as well. In this white section, it's going to tell you lots of things. It's going to tell you a timestamp, okay? Which I think it goes like every 20 minutes maybe. I don't know. It'll tell you what time it is. It'll tell you what kind of monitors your patient is on. Your blood pressure and your pulse will be there when we take vitals, okay? So that's what that little white spot there is. All right, so we're going to talk about the contractions here, right? The powers, that's what we're on here. I don't know, there's nothing written here. I don't know what kind of monitor this patient is on, because again, whatever segment that I took a picture of didn't have it, which was unfortunate on my part. All right, so let's look at this picture. From this red line to this red line is 1 minute. So all the red lines and the red lines are a minute apart. That's the first thing I want to tell you. In a perfect world, you guys, and it's not. In a perfect world, every contraction would start on the red line. It sure make your job a lot easier as a student trying to figure this out, but that doesn't happen. So what you're going to do when you're going to have a bigger segment at this, you're going to find the timestamp and you're going to open up your strip to have about 30 minutes of tracing on there. I don't have that here. I've got, let's see, if this is a minute, I've got 1, 2, 3, 4, 5, 6, 7, 8, 9. I have 11 minutes here, which is okay. I mean, it's not great, but it's good enough. Okay, so when you are in practice or at orientation, I want you to open your strip and I want you to find a time, 2 timestamps that gives you at least 25 to 30 minutes. It makes your job a little easier here. All right, we have 11 minutes on this picture. So I already told you we're to frequency, duration, and strength. So how frequent are these contractions? Remember, frequency is how far apart they are, how often they're coming. And you measure frequency by the beginning of one to the beginning of the next. So this is the beginning. Would you all agree? That one's on the line. That's handy. That's the beginning. That's the beginning. And that's the beginning there. Okay, so those are all of your beginnings. We're going to switch pen colors. I think it'll be easier for you. Let's do red. All right. So we're going to measure so that if you see this red line here, I know you do, and this red line. Now, this contraction doesn't start on the red line. It kind of starts halfway through. So your minute, if you will, is halfway through here. So 1, 2, 3.5. So the frequency between the start of this contraction and the start of this contraction is 3.5. This one actually lands on the line. That's nice. 1, 2.5. Let's do this one. So here's our line, right? And here's our line. Let's just call it halfway to make our life easier here. So halfway. So we're going to go halfway to the next box. So 1, 2, I would say 2. So that's what I have on this strip. I have a frequency of 3.5, 2.5, and 2. So what does that mean? So how do you document that? So it's always a fraction. So you put the shortest over the longest. So the frequency of the contractions on this patient in this 11 minutes, the shortest is 2. 2 is on the top. The longest is 3.5. So in this small little segment, this patient is contracting every 2 to 3.5 minutes. Great. Okay, so let me get my eraser. Is that what this is? Let's see if I can erase here. Oh my gosh, isn't this great? So we're erasing now. Now we are going to talk about duration. Let's do duration in green. All right, it's always going to be shortest to longest again. So this still applies. So now we're doing duration. Remember, duration is the actual length of our contraction. So let's go ahead and find the beginning and the end. That one's kind of cut off. Each one of these little boxes is 10 seconds. So let's count. 1, 2, 3, 4, 5, 6. So 60 seconds here. 1, 2, I'm getting myself confused. 2, 3, 4, 5, 6, 7, 70 seconds. 10, 20, 30, 40, 50, 60, 70, 80. 80 seconds. And I cut that one off. So if I'm looking shortest to longest, I have got 60, which is this one, over 80, which is this one. So my frequency is every 2 to 3.5 minutes. My duration is 60 to 80 seconds, and my strength I have to palpate because I don't know what kind of monitor I have here because I didn't capture that. I would ask my patient and I would palpate. That's how you do that. Let's do another one. All right. I can't remember what color I used. Blue, I think. All right, so I'm not going to do all my little hints, but look at these ones. I would hope you're being like, oh boy, these are close together. Look at this. There's only 20 seconds there. So we've got 1, 2, 3, 4, 5, 6, 7, 8 contractions in this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So 11-minute strip again. I must see what I can fit with my camera. So our strip total there is 11 minutes for timing. So let's talk about frequency. So I want you, well, I'm going to do it with you since I'm doing this with you right here. I would say these contractions here are probably very close together. So here's our red lines. So it starts here at this 2 into this red line, and it ends 2 into the red line. So from the start of this one to the start of, oh, I lied. No, let me start again. I'm going to erase. Sorry. Just a second. Let's start again. I love the erase thing on this. All right, let's do this again. So this contraction starts here, and this next one starts here. So I would say that this contraction, so I'm counting this out, this is 1, because we're halfway, 2. So these 2 contractions are 2 minutes apart. This contraction starts in the middle, and this one ends over here in the middle too. So we have 1. This is only 1. From the beginning of one to the beginning of the next is 1. From the beginning of one to the beginning of the next is 1. These contractions are close together. All right. Let's count this one. It's 20 seconds before your big line. So we're going to stop here. 1.5. So this is 1.5. So our frequency in this strip is 1 to 2. Our frequency. Let's do that. And you don't know this yet because we haven't taught you, but this is not great. Your baby's having some compromise here. Okay. All right, now let's talk about duration. I want red. And let's erase this. So now we're talking about duration. How long are they lasting? Remember, each little box is 10 seconds. 10, 20, 30, 40. Let's find a big one. 10, 20, 30, 40, 50, 60, 70. Maybe there's a smaller one. Let's try this one. 10, 20, 30, 40, 50. So I would say our duration is 40, oopsie, to 70. That's our duration. And our strength, again, I don't know what kind of monitors I have. I would ask and palpate if I didn't know what kind of monitors that the person had. I want to teach you one thing about fetal monitoring, and that's all I'm going to say until you have orientation. Up here is the baby. On the bottom are the contractions. Okay? When you are, after you're at orientation, when you are taught how to read a fetal strip, there's an order of operations. The first thing, 1, what is your baseline? That's the first thing. The second thing, is there anything above or below your baseline? Okay? And then variability. Okay? So you want to make sure that you always start with your baseline. Don't start with whatever these are. Start here. All right? Just like if you're evaluating labs on a patient, start with your baseline. Okay, that's all I'm going to say about that for today. All right, let's do this one. This one I'm not going to go through as much because this is now our 3rd time doing this. There's only 3 contractions on this strip. That is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. That's all my phone can fit. All right, so 3 contractions and 11. And if we are doing frequency, the beginning of 1, so that's kind of in the middle, to the beginning of this one. So this is like 10, 20 seconds in. All right, so 1, 2, 3, 4, 4.5. 1, 2, 3, 4. So here my frequency is 4 to 4.5. My duration, let me get an eraser because it's confusing me. All right, let's do our duration together here. Okay. 10, 20, 30, 40, 50, 60. Where am I starting? 10, 20, 30, 40, 50, 60, 70. So this isn't a great strip. I would say 60 to 70 is my duration. And strength, you're going to palpate. All right, let's do this one. We're not doing the baby. We are doing, because babies are in trouble, right? We have a problem. These aren't good, but that's a different day. All right, our contractions. There's a contraction there, 1, 1. All right, so this isn't very straight. My apologies. The beginning of one to the beginning of the next. This one starts 2 lines over from the big red line. So 1, 2, 3. 3 minutes. This one starts 1 before the big red line. 1, 2, 3, 3 minutes. This one starts on the big red line. 1, 2. So my frequency is 2 to 3 minutes. My duration, we're going to count. 10, 20, 30, 40, 50, 60. 10, 20, 30, 40, 50. 10, 20, 30, 40, 50, 60. 10, 20, 30, 40, 50, 60. So your duration is 50 over to 60. And again, without knowing what kind of monitors this person has, we're going to ask and palpate. Number 4 of our P's of labor is the position. Ideally, this client should change their position often. All right. The more the mom turns, the more the baby turns, and it gets into the right position a little better. Gravity is good for pushing. You can use squatting. Now, an epidural is going to you have to get creative. We're all very creative labor nurses, but you have to get creative. You can push on your side. You can push while seating. You can use birthing balls, all kinds of things. But the more you move, the better. All right, in a nutshell, if your patient believes that they can't do it, they won't do it. Oftentimes, your patients will bring in the whole neighborhood or their aunties and their cousins, but it's our job as labor nurses to empower the family to help this laboring person. If they've never been in the hospital before, they're nervous, or if they've had multiple hospitalizations, they're nervous, they're excited, and they're nervous. So our job is to teach them and support them so they can believe that they can do this. The middle part of this lecture talks about the procedures that assist with labor and delivery. And there's a bunch of them, right? Let's talk about the version. That's the first thing we're going to talk about. In the beginning of the lecture, I talked about the baby that was in the wrong position. Transverse lie, oblique lie, breech, okay? Not really footling breech, usually just regular breech, okay? So an external version is a procedure that the delivering doc can do that will help, well, that's not true, with the goal to turn the baby to cephalic position or vertex so the person can have a vaginal delivery. That's the best way to say it. A couple things about a version. We do them when they're close to delivery, so 37 to 38 weeks. It is a consented procedure, so and it's up to the patient. It's up to the doctor or the healthcare provider to give all of the risks and benefits, and the patient decides whether they just want to have a scheduled C-section because the baby's in the wrong position or they want to try to turn the baby, all right? So let's say for this slide that the patient decides they want to turn the baby. They're going to come into the hospital. They're either going to get admitted for a few hours, depends on the doc. They're going to sign consents, and the nurse is going to put the baby on the monitor, and we're going to get a non-stress test, which you're going to learn about in week 2 on your home lecture. But a non-stress test lets us know the baby is not stressed out, non-stressed. Not stressed out, okay? So we establish fetal well-being. That's what this does, establishes fetal well-being. All right. We make sure nobody's in labor. And then we're going to, like I said, we're going to gather our equipment. So our equipment, we really don't do too much with this. We assist more than anything. Okay. So we assist with getting them consented. We run the NST on the baby. And then we're going to gather the ultrasound. Okay. And sometimes the docs will order some medications to help relax the uterus, because to turn a baby, you have to push hard externally on the uterus. And so They sometimes will, some docs will have a patient get an epidural because they don't feel it then. Other docs will use what we call a tocolytic, which we get to later on, which relaxes the uterine muscle so they can try to turn the baby. It's risky, right? There's a risk of what's called a placental abruption. I teach you about that in detail. We do in week 4 in the antepartum high risk lecture. But what an abruption is that the placenta detaches from the side of the uterus prematurely. So the thinking is that as the healthcare provider is, they do an ultrasound, they see where the placenta is at, and then because they don't want to pull the placenta off the side of the uterus, so they're going to try to turn the baby. And there is a risk that the placenta might tear off during this. That's an abruption, which is a fetal emergency and a maternal emergency, if I'm being honest. Umbilical cord compression, and then emergency C-section because of those two things. These are the reasons why we do not do aversion. So how does this work in the real world? Like I said, they're going to come in, we're going to consent them, we're going to run for an NST on the baby, and we're going to gather our equipment. So some docs will come in and try to avert the baby, turn the baby, and they could either turn the baby successfully and admit the person and induce their labor, or they could turn the baby successfully and send them home and tell them to come back when they're in labor. Is there a chance the kid will turn back? Yep. And if it doesn't work, and then just get sent home and scheduled for a C-section. Okay, this next slide talks about the things that we can do. Again, we're still talking about things we can do to help somebody with their labor to progress or to get it started. So there's something called cervical ripening, which this whole slide is about. There are reasons why we have to do this. Now, if somebody has an uncomplicated pregnancy, they go into labor all on their own, we're not doing any of this because we don't have to assist, right? Because the body's doing their own thing. But these are the people in this portion of the lecture that need help with getting their labor going, all right? So cervical ripening. So when labor is ready, I have to rephrase this. When our body is ready to go into labor, if you were to do a pelvic exam on somebody who is in the early stages of labor, their cervix palpates, it's soft. It feels kind of like the cheek on your face. That's our goal, right? So that's somebody who's in labor all by themselves. But if we're having to help somebody's get their labor started, assist with their labor, we need to do a pelvic exam and we need to palpate their cervix. Is their cervix soft like your cheek, or is it hard like your nose? Okay, if it's hard like your nose, we must begin with this step. We must make the cervix ripe, i.e. soft, okay? A ripe cervix, think of like ripe fruit, right? If you have a nice avocado that's nice and soft, it's ripe, let's eat it. So with your cervix, when it's ready to go into labor and have labor start, it's soft, okay? But if there's a reason we have to get somebody going into labor, which is called an induction, right? And how do we have to do this? If they're having complications of their pregnancy, and we go into that in a second. So we do a pelvic exam. If their cervix is firm and it feels like your nose, we have to do this step first. But if it's soft, we skip this step. All right, let's just say our patient's cervix is firm or it's hard. So we do a pelvic exam. We establish fetal well-being all the time. That's our job. And then we're going to get on the phone with our healthcare provider and say, okay, Dr. So-and-so, I have your patient here, gravida and para, on and on with all of that. NST is reactive or whatever's going on with that. And I check their cervix and their cervix is hard. And you need to give me orders for one of these two things. We don't do both. So they're going to pick the one they want to do, and then you're going to run with it. And you have standard order sets for most of these things. So they're both prostaglandins. Prostaglandins cause the uterus to be irritable. Doesn't necessarily cause whopping contractions, but it does cause uterine irritability. Misoprostol is a type of prostaglandin, and we use it. You can give it for this lecture, PO or vaginally. All right. We also give it, just as a side note, we talk about it in the postpartum lecture for controlling a postpartum hemorrhage. Okay. But for this lecture, it's for getting somebody's cervix ripe so we can induce their labor. Gets that cervix soft. Depending on your hospital policy and your healthcare provider, PO or vaginally, follow your policy. If you're going to put it in vaginally, make sure they get up and go pee first, empty their bladder, because once you put it in, you have to keep them flat in bed for an hour, or not really flat, like in a very low Fowler's. And then you redose every 6 hours. Nothing's happening fast. If somebody is having an induction with these kind of meds, you will see this in clinical. Chances are real good your clinical faculty is not going to sign you to them because they're not having a baby on your shift, more than likely. Because you redose every 6 hours for up to 4 doses. So you can do the math. That's a whole day before they even start having contractions. All right. So if it's getting, so let's go ahead. I'm going to walk you through this one because this is the one that I'm most familiar with, but I can do this one too, but we'll start with misoprostol. We have an order to give it, and then so we establish fetal well-being, we give the medication, we have them lay in bed if it's vaginally for an hour. If not, we want them to get up and walk around, okay, because hopefully the walking around will cause some contractions, which will help that cervix to get soft. Usually they can eat because they're not delivering on this medication, it just gets the cervix soft. When we're getting close to the 6 hour mark, we're going to do a pelvic exam on them. And if their cervix is not soft yet, we're going to redose them and do the whole thing again, up to 4 different times. Okay? So with the dinoprostone, this is actually what this looks like. It's soft, okay? And your hormones in this the disc thingy there. And here's this picture too. It doesn't go through the cervix, right? Because here's the baby. It goes to it's called the posterior fornix. So you're going to place it kind of like a scarf, if you will, on the back of the cervix, okay? And then this little string comes out, and that's how you take it out. So it stays in there for 24 hours. At 24 hours, you pull it out. Hopefully the cervix is nice and soft, and then you start Pitocin, all right? So with both of these, whenever you've reached the end of either one of these treatments, the next step is usually Pitocin to get the contractions started, because this is not, the goal of this is not for contractions. The goal of this is to make that cervix soft. All right, so these are the things that you're continuing to assess for, and these are the complications. Now, why are they complications? Because somebody can have contractions. The complications of too many contractions is this word tachycystole. You've talked about that. This is the tocolytic that we give. I have a whole slide for it in a little while to make the uterus stop contracting. We talk about it in the antepartum high risk lecture too. If your baby is experiencing fetal distress, these are the things you do, okay? The reality is they're all done at the same time. In this class, we will not ask you, what are you going to do first, okay? As long as you know what to do, that's what we want you to know. All right, so now we're going to talk about an induction of labor. You've heard of somebody being induced. When somebody is being induced, it's because they're not contracting on their own, and we need them to start contracting for different reasons. So an induction is the intentional initiation of contractions because they're not contracting on their own. All right, and these are the reasons why we might need to send somebody to labor and delivery for an induction of labor. All right. Client medical conditions, if they have hypertension in pregnancy, those kinds of things. Their pregnancy is overdue. Prolonged rupture of membranes, intrauterine growth restriction, baby is too small, it's not thriving. Fetal demise, baby has passed away inside the uterus. Chorioamnionitis, an infection. Okay, those are the reasons why we do it. We don't just do it because the mom's tired of being pregnant anymore. We used to. I was induced for that reason, but we don't do that anymore. When don't we do it? When there is a scar on your, okay, let me pause. Whenever you have a scar on your body, whether it's on your arm or your leg or on your uterus, that's an interruption in that skin or the muscle, so it's weaker. So if there is a uterine scar and we don't know which way it goes, you can have a scar this way, you can have a scar this way, okay? If we don't know where that uterine scar is, they're not going to give this person medication to make this uterus contract, which is a risk of something called dehiscence. And we have to make sure that doesn't happen, okay? So where would we find the documentation of uterine scars? There's something called a prenatal record. What the prenatal record is it's the every visit, everything that happens in this pregnancy before I meet them in labor. All of their lab work, all of their ultrasounds, any diagnostics, prenatal screening, seeing their doctor, all of those things. Also, your pre-op reports or your op reports for somebody who's had previous C-sections are going to be in there too. So that's where you're going to find that. You're not going to give somebody Pitocin or induce their labor if the baby is having fetal distress or if we have a placenta previa. All right, I'm going to stop for a second and explain that a tiny bit. This is covered more in week 4, but just for today, I want you to understand where a placenta is supposed to attach is posterior fundal. When you have got a previa, the placenta is, I'm going to change my colors. I'm going to pick blue. Your placenta is detached low, next to or covering the cervix, okay? You do not deliver vaginally with the placenta previa. So there's no point in making somebody's labor start when they're having a C-section for placenta previa. There's different ways that we can induce somebody's labor. We can break their bag. Now, I will say that in the state of California, bedside nurses, which is the program that you're in, we are not in an advanced practice nursing program. In the state of California, by the Nurse Practice Act, we are not covered to rupture bags. Other states, I can't say. I've never worked anywhere else. So know where your limitations are by your license wherever you work. You can give IV oxytocin or Pitocin, or you can have the person do nipple stimulation, which releases internal oxytocin. So basically, or you either can rupture their bag or we can get them to contract. And this, I've already covered the risks of that. All right, so let's talk about induction of labor using Pitocin. So not nipple stimulation. We're going to talk about, we're going to start an IV and we're going to start Pitocin to make them have contractions. All right, so your patient's going to come to you in labor and delivery with orders for an induction of labor. Even if they just got checked by their healthcare provider or your best friend checked them, but you're going to start the medication, you must double check them again. Because you, by the person who's giving the medication, must confirm that things are where they should be. Is the baby head down? That's your first thing you have to ask. Is the baby engaged? Maybe or maybe not, but certainly it better be head down. You do not start Pitocin on a baby that's not head down, because babies that are not head down, cephalic, are going to be having a C-section. All right, so establish the baby is head down by a vaginal exam. All right, you're also at that point, you're going to establish that is the cervix soft or is it hard. If it's hard, you're going to go back and you're going to use the misoprostol or the prostaglandin like little tampon thing. But assuming the cervix is soft, we can go ahead and we can start with the Pitocin. Always establish fetal well-being. The fetus is your patient too. So you have to establish fetal well-being, and you do that by learning how to read the baby's heart rate. So you're going to establish that. If your patient, these two sentences here talk about your patient who has had the first step that makes the cervix right. All right, so you can't double dip on your medications to make you contract. So that's the parameters for that. Infuse at the port closest to your patient. All right, so think back. If you're looking at an IV tubing, right, and there's all kinds of ports you can attach things to. The top port, you're going to have your lactated ringers going on as your primary line. Then your top port can be where you administer your antibiotics, right? You've done this before. And then as you get down, you're going to see a couple more ports that are coming off of that tubing. And the port that's closest to the patient is where you're going to hook up your secondary main line. You're going to have two main lines going. Your secondary line of oxytocin. All right, don't put it high up on the tubing. You want to make sure it's low to the patient. It goes in very slow. And so the closer it is the patient, the sooner they're going to feel the medication. Whenever you're giving a high-risk medication to any patient, I don't care where you work, but certainly in this department, you're going to increase the frequency of your assessments because now they're on a high-risk medication. Pitocin is a titratable drug. Basically, the goal of the Pitocin is to make this person contract with the goal to get them to be painful contractions every 2 to 3 minutes. That's our goal. Okay. So we titrate it to get them into that space. You are not titrating medications in this class. I want you to understand why the nurses are doing it. You are to talk about it on your care plans and understand what the medication is, but you are not titrating Pitocin in this class. Okay, so we're still on procedures to assist with labor and delivery, right? We talked about Pitocin, right, to help kind of induce labor. we're going to talk about something called an augmentation of labor. What an augmentation of anything is to make things stronger, make things better, make things bigger. You're augmenting, augmented reality, you can put augmentation in front of all kinds of things. Breast augmentation makes the breasts bigger. An augmentation of labor is to restart, make the contractions stronger because they've kind of pooped out. All right. So this would happen if your patient came into the hospital and they're in labor. They've come in, their cervix is dilating because, as you know, labor is cervical change, right? So their cervix is dilating, their contractions are strong, they're moving along. So fast forward 6 hours from now, their contractions have gone away or just decreased in strength and frequency, and their cervix has stopped dilating. This person needs an augmentation, kind of a kickstart to that labor because it kind of slowed down. So you can augment somebody's labor by starting them on Pitocin, okay, or by artificially rupturing their membranes. Now remember, we can't do this as bedside nurses here in California. So let's talk about if we're going to augment somebody's labor by starting them on Pitocin. Just like the previous slide, when you're inducing somebody's labor on Pitocin, you turn the medication up every certain amount of time to get them in a good labor pattern. Okay, here they came in a good labor pattern, but now everything is slowed down. So we call our healthcare provider, we do an SBAR, we're recommending an augmentation of labor, and then they decide if they want to use Pitocin or come break a bag. That's not my call. And so if they say, go ahead and start Pitocin, there's standard order sets for that. I start my Pitocin. Typically, the person needs less than if I was straight up inducing them because their body already started doing this on our own. I'm just kind of kickstarting it, okay? All right, let's talk about an AROM, artificial rupture of membranes. You'll see we short it as AROM as opposed to spontaneous, which is just SROM. Okay, so we use something called an AmniHook, and you will get to see this in clinical orientation. And what we do is we assist this procedure by gathering the equipment and by helping the patient get into the right position. So you don't want to lay them flat, but you want to lay them kind of in a low Fowler's with a little wedge under the hip. Make sure there's a chucks under them because we're going to break the bag and they're going to be wet. And then you want to make sure that you have a clean chucks and you want to have gloves on too. So the doc's going to go in, they're going to go ahead and break the bag, and the fluid that comes out should be clear. Wherever someone's fluid ruptures, whether it's spontaneous or artificial, we need to make sure that we know when the time is and what the color is, okay? So you want to document the time and what the color is. Note here, there should be no color. If there's color, we're concerned. Is it meconium stained fluid, which is kind of like a greenish color, meaning the baby passed its first stool inside, shouldn't have done that? Or is it bloody or anything like that? It should be clear, just like water coming out of your tap. There should be no smell. If there's a smell, that leads me to think that there's an infection somewhere, okay? Typically, labor begins with 12 hours after rupture of membranes. We do not rupture, or we should not, since we don't rupture, we should not break bags, or the docs should not break bags unless the baby is engaged. I already told you why, you know that. Something I kind of want to throw in here, I think it's probably somewhere else too, but once somebody's water breaks, regardless if it's an artificial rupture or a spontaneous rupture, a clock starts. Now, what that means is that we don't want them to be pregnant forever with rupture membranes because there's an increased risk of a fever. Of an infection, right? So we're going to go ahead and we are going to write down the time, right? I said that, and the color and all of that jazz, okay? So we need to know, as their healthcare providers, if they're been ruptured 7, 8, 9 hours, as long as they're afebrile, I'm okay. But as we're getting to 16, 17, 18, 19 hours of being ruptured, it's risky, right? The longer you're ruptured, the bigger risk you have of having an infection, okay? All right, so procedures to assist with labor continued. Something called an amnion fusion. When somebody's water is broken, the water continually leaks out of her body until the baby is born. When somebody's water is not broken, the amniotic sac is full of amniotic fluid, and the cord is protected and the baby's protected, okay? But as your water breaks, you can have cord entrapment, okay? And so cord compression. I like that better. Cord compression. All right. And how you know there's cord compression is something called variables. You're going to learn all these words in orientation. So this right now might be a little confusing as why we do it, but I'm going to try to teach it to you even though you don't know what that word means. All right. So if somebody's water is broken, there's less fluid to cushion the umbilical cord. So the umbilical cord can get squished or compressed, which causes the heart rate to go down. Okay? Those are called variables. And those are not great. We don't like that. We don't want any kind of decrease in the baby's heart rate. So if we are seeing recurrent variables on the monitor, I'm going to call my healthcare provider and give my S-bar, right? Which you guys are going to get really good at. And my recommendation is an amnio infusion. And what an amnio infusion is it puts in sterile water. The book also says lactated ringers. I personally have never used that, but that's what the book says. So in case you see your nurses doing that. So what this is you're going to get an order for an amnio infusion, and all an amnio infusion is putting back the water to help decrease the cord compression. More, you want to make a bigger cushion for the umbilical cord. All right, so a couple of things you have to have in place before you can do an amnio infusion. They have to be ruptured. So if they're not ruptured, my R is to get, can you come break their bag? And then can we start an amnio infusion? Because I cannot break bags, right? So it depends what's happening with your patient. So if they're not ruptured, take care of that. Best use a blood warmer, okay? So what you're going to get is you're going to get an IUPC. Remember, this is to pick up contractions. But on the end of it, when you see it in class, you can plug your amnio infusion into the IUPC. All right? So what you're going to do is you're going to go into the supply room. You are going to get, we're going to say normal saline, and it's just a big 1,000 milliliter bag, and you're going to get IV tubing and an IV pump. And you're going to walk into your patients, and if they don't already have one of these in, we can put this in, and you're going to explain to them, you're going to say something like this. Hi, patient. Your baby, every time you have a contraction, the baby's heart rate's going down a little bit, and I think it's because the amniotic fluid's coming out. So what I'm going to do is put some sterile fluid back in to help relieve the compression of the umbilical cord. And they'll say, okay. All right, so that's what I do. So I'm going to go with the scenario that they're ruptured because I can't do that. But I'm going to go ahead as a nurse. I'm going to put my IUPC in, and then it's going to record my contractions. Then I'm going to take my normal saline and I'm going to prime my IV tubing. I'm going to plug it into my IV pump, and then I'm going to attach it to my IUPC, and then I'm going to give a bolus of fluid in through the IUPC into the uterus, okay? And whatever my policy says, for however many long, I'm going to give the bolus, and then I'm going to slow it down. And this is going to keep going in very slowly until this patient delivers, okay? And then, so what that means for me is that I'm going to have to do really solid pericare because she's going to be leaking this fluid continually until she delivers. All right, we're still in the procedures here to assist with labor and delivery. So we're going to talk a little bit about vacuums and forceps. So you'll have all of this in orientation to look at too, so you can kind of put your hands on it. So a vacuum is just a cup-like suction. This is not done by nursing. Our job is to look at the timing of the patient, how long it's on the baby's head and how often, okay? So why do we use it? We need to make sure that the baby has to be head down, right? Because basically the baby's kind of stuck. It must be at least a +2. Do I have that written anywhere? No, I don't. So we must have the baby needs to be at a +2 or a +3 to use a vacuum. Okay, no higher. We need to make sure that the baby's head down, that there's no CPD, cephalopelvic disproportion. How do I know? I only know because the patient's been pushing for hours and hours and hours, but the baby's head is not at a +2 or +3. All right? She must be ruptured, and we are not doing it on preterm babies. All right. Is it risky? Most of the risks are for the baby's head because you're putting a suction cup on the baby's head and pulling. So it's mostly the risk for the baby. Why do we do it? If your baby is so close to being born, but your patient can't push anymore. She's been pushing forever and she just has no more strength left. You're going to call the doc and you're going to say, here's your S-bar. My recommendation is, can you come evaluate the person while they're pushing maybe we can use a vacuum on them, and then they'll come and do that, okay? Fetal distress during the second stage of labor. Yes, your book says you can do that. However, in my experience as a labor nurse, if there is true fetal distress, they're not going to put this on the baby because that's going to be stressful as well. If there's true fetal distress, they're probably going to take the patient to have a C-section. So how does this work? The patient's going to probably be up in stirrups at this point. They're going to put the vacuum on when she's not pushing, and they're going to squeeze the lever and just put it in. There's different zones. There's a yellow zone, a green zone, and a red zone, and that's how much pressure is on the suction cup. So you put the suction cup on the baby's head when they're not pushing, give it a couple squeezes so the dial's in the yellow zone. As soon as she starts pushing, squeeze it, I don't know, 3 or 4 times. And then so the dial's now in the green zone, and then she's pushing and you're pulling. Well, the doc's pulling, and that should pull the baby out. Most hospitals have what is a pop-off policy, which means that if the suction cup pops off, you document that as one pop-off and you finish the contraction. Then the next time they're resting, you put the cup back on, okay? Put the dial into the yellow and wait. When they start pushing, squeeze the dial into the green and pull again. Baby should come out at that point. If it doesn't, the suction cup pops off. That's your second pop off. At that point, the patient should be taken into the operating room to have a C-section. Forceps or something else that you'll get to look at in orientation. Here's the picture. It's different. Now this, when I copied this baby has a very long head, so forgive me. But forceps are not a suction. Forceps go inside and they lay. This one kind of goes deep. I'll be honest with you. Most of the forceps come right here to go right alongside the baby's eyes. So you put one on one side, one on the other side when they're not contracting. Again, just like the vacuum, you want to put the forceps in when they're not contracting, and then you wait, okay? And then when they start pushing, you're pulling, and the baby should come out. Now, the couple of things, again, lithotomy is good. They both should have their bladder empty. The baby should be at a +2 or +3 for your forceps. And cervix must be 10 centimeters for both of these to be used. There's more risks, again, for the baby, but the risks really aren't at the head. The risks are more where we have these pressure of the forceps, which is right along the side of the baby's face, right outside next to the eye. Risk of facial bruising and palsies there too, okay? Why do we use forceps? Again, prolonged second stage and they're tired of pushing. Fetal distress, okay, as long as the baby's like getting ready to be born in seconds, otherwise they're doing a section on her. This came out of the book, but you won't see this too often. All right, and arrest of fetal rotation. Not too common anymore. The next couple slides talk about episiotomies and lacerations, and I'm going to change color because I want to look at a different color. An episiotomy is a incision that is made. We are not doing this as bedside nurses in the state of California. It's outside our scope of practice, okay? But it is an incision or a cut, if you will, a small cut. And we're talking like a centimeter long. It's not a big cut. Usually at the perineum, and it enlarges the opening so the baby can come out. Why do we do it? To shorten the second stage of labor, which is the pushing, right? To help us get on vacuums or forceps. This right here came out of your book. My argument here is if somebody is early enough to be declared a fragile preterm infant, they're going to do a section on them. I'm just saying. And then facilitate the birth of a large baby. That's also why we do it. All right, so there's 2 different kinds. There's a midline episiotomy and a medial-lateral episiotomy. Everything comes in and out of favor. When I first started practice, it depends on your nurses. You might find young nurses that only been out for a couple of years. They probably never see this anymore. They never see forceps deliveries anymore. But as the longer you're in a profession, the more you see things kind of coming in and out of practice. So it just depends on how these docs are being trained or these healthcare providers are being trained. All right, so let's look at your midline episiotomy. Now, this is a very dramatic picture because it shows that the incision is very long. Truly, it's not that long at all. But a midline episiotomy comes from the middle and goes down and aims towards the rectum, okay? It is the most common, all right, because it's associated with less bleeding and less painful compared to this one for your moms, all right? for your patients. It is associated with the higher incidence of a third and fourth degree laceration because it can extend into the rectum. It doesn't usually, but it can. Now your medial lateral, I'm going to do that in blue, okay? So your medial lateral goes off to the side, as opposed to going straight down towards the rectum. It hurts more, it takes longer to heal, and there's more blood loss on a medial lateral versus a midline. So what is my responsibility here? My responsibility is to make sure that my healthcare provider has the equipment they need. Do they have the sutures? Do they have scissors? Do they have local if the person has no epidural? And then to document. But I don't do any cutting at all. That's not within my scope of practice. All right, a bit about lacerations. So laceration is just injury to the tissue. It's just a cut. You can have a laceration when you fall and scrape your knee. You can have a laceration if you run into the wall when you're walking down the hall or whatever. All right, so this is a perineal laceration. So we can have first, second, third, fourth, and sulcus lacerations. And again, this is tearing of the skin. We are not cutting the skin here. It tears by itself because of the delivery. And it's measured by the depth, not the length, I guess is the best way. All right. Certainly the first and second degree, I'm gonna rephrase that. The first and second degree are measured by depth. When you have the second and the third and fourth degree, we have some of the rectum coming into it. So that gets a little bit longer. All right, so your first degree is just the skin of the perineum and the vaginal mucous membranes. This is the most common. Your first degree is the most common, okay? And your second degree, you can see it encompasses all of the first degree as well as the fascia. Your third degree encompasses all of the second degree as well as it's going into the rectal sphincter. So now we're getting a little bit longer and deeper here, right? Your fourth degree goes through the rectum there, okay? So that gets a little bit more intense. A sulcus tear is when you have a laceration that happens on the lateral sides of the vaginal walls. So a little bit here about C-sections. I think there's 3 slides that go with your C-section conversation. So cesarean birth is the delivery of a baby through an abdominal decision. You can have a classical, which is a vertical cesarean, or a cervical or low cervical transverse cesarean section. 2 different kinds. But it's major surgery. You don't just have an elective C-section for no reason. There was a period, I will say, sure, there's a period that we did that, but they were having more complications. So it is now recognized that it is a major surgery. So there has to be a medical reason or a reason for a C-section. Problems with our placenta. The pelvis is too small to get the baby out. Complications of labor dystocia. No matter what you do, you cannot get this client into a good labor pattern. Those contractions, those powers, right? Those powers are not strong enough to provide these strong enough contractions to get that cervix to dilate. Malposition, I've talked about that. Previous C-section, if somebody's had a previous C-section, they can have another C-section. That's fine. Non-reassuring fetal heart rate status, you're going to know what that means after you go to clinical orientation. Certainly somebody with a high-risk pregnancy, they might be offered a C-section. Multiple gestations. If somebody has multiple gestations, they're usually offered a C-section, even if both babies are head down. It becomes the right of the person who's pregnant to decide what they want to do. And then a cord prolapse, we're going to talk about that. Sure, there's complications because we are having major surgery happening. So let's talk about the complications of the pregnant client. Here, these are just mostly complications that you're going to experience when you have surgery. That's something that is unusual. Complications to the baby, lacerations mostly to the face because as you're cutting through the uterine muscle and then the membranes, if you're going too fast and not being really intentional, you can lacerate a baby's face. I've seen it once or twice over the many years I've done this. Increased respiratory complications and NICU admission. I'm going to explain why. So as you're studying, and you're at the beginning of this class again, you're going to see the cardinal movements. I talked about that. And as you're reading through them, you're going to see as the baby is descending into the pelvis. When the head of the baby is out for that couple seconds, but the chest is still inside the pregnant client, the muscles around that baby's chest squeeze the baby. It's called a thoracic squeeze because the muscles of the mom are really tight. Head's out, body still in, just for a second. The muscles of the mom squeeze the thorax of the baby, and the baby kind of spits out any residual amniotic fluid that's left inside of its lungs. Okay? So, mommies that deliver by a C-section, that thoracic squeeze is missing because they're coming out of the abdomen. So because because the thoracic squeeze is missing, there can be retention of amniotic fluid. And retention of amniotic fluid leads to respiratory complications, which can lead to a NICU admission. That's the cascade effect of that. All right, now we're going to talk about the different kinds of C-sections. I told you there was two. Low cervical transverse, this is the one that you're going to see in clinicals more than likely. I haven't seen a classical C-section in so long. It's just riskier. So the most common C-section that you're going to see, low cervical transverse, basically it's right over the bladder. And it's, I don't know, an 8 centimeter incision, not real big. Less blood loss, less adhesions. If somebody has a low cervical transverse C-section once, the next time they get pregnant, if they wanted to have a trial of labor after a C-section, they can, okay? So now we're going to talk about the classical. So the classical basically, so here's the uterus, right? I'm going to switch colors. Your low cervical, they're cut here. Okay, that's really, really, really big. Let's just not be so dramatic. Let's train this whole thing all over again. All right. Let's draw the uterus. Let's draw a big uterus. Okay, so here's, there it is. And then your low cervical is right over the bladder, okay? Your classical is a vertical incision from where right over the bladder to the fundus. So that whole muscle is cut, okay? So why is that a problem? Well, the whole muscle's cut. So that muscle, the entire muscle is weaker now because of the interruption in the skin integrity there, all right? It makes that muscle weak. So once somebody has a classical incision or a vertical incision on that muscle, every future pregnancy must be delivered by a C-section. Somebody cannot labor on a scar that is a vertical scar. How do I know? It's on the prenatal record, okay? So when you're talking about, anyway, I'm going to pause for that. Okay, so what do we do about this? We don't do the C-section, right? Unless we're RN first assist. You can go and when you finish school, and you can go and be first assist, and you can do scrubbing in on surgeries. But that's not the school that you're in right now. So what do? We admit them. We run an NST. We establish fetal well-being. We put a Foley in. We get IV access. We start an IV, like I said. We're going to consent them for surgery, all those kinds of things. You guys will get to see a C-section in your clinical rotation. All right, these two things. Trial of labor after a C-section, we shorten that as TOLAC. Vaginal birth after a C-section, a VBAC. They're very similar. Here, this person who's doing a TOLAC, we're having a trial of labor. They haven't actually delivered yet. We're trying it out after they had a C-section. Once they've delivered vaginally, now they're a VBAC because they've had this vaginal birth after C-section. That makes sense, right? Okay. So what needs to be in place before somebody can have a trial of labor after a C-section? Previous documented low cervical incision on the uterus, right? We just talked about that. Somebody who has that vertical incision may never labor on that scar. No way. And you're going to find that in the prenatal record, okay? No evidence of fetal macrosomia, no other scars on the uterus, no more than 2 prior C-sections, because the more times you cut that muscle, the weaker it is. Why did your patient have the C-section? You can have a C-sections for fetal reasons and maternal reasons. If fetal reasons, breech, cord prolapse, I don't know, fetal intolerance to labor, things that only are associated with the fetus. When that baby is delivered, those issues go away, right? Or was it a maternal reason? Hypertension in pregnancy, CPD, I don't even know. Things that are only associated to the mom. So if it's a fetal reason last time, the chances are pretty good they'll be able to have a successful trial of labor. But if it's a maternal reason, like their bones were too small, the bones don't get any bigger. So they might counsel against that of having a trial of labor. That's why you want to know that. Always establishing fetal well-being, always assessing contractions, assessing for uterine rupture. And how do you know that? Is when somebody's uterus has ruptured, their uterus looks different. It's not the round pregnant belly you're used to seeing, because when the when the uterus ruptures, the baby goes outside of the uterus and is now in the abdominal cavity. Babies can die very quickly. So the first thing you're going to notice, if they have an epidural, they won't have pain. If they have no epidural, when that scar opens up, it's very painful, okay? But if they have an epidural, they won't feel it, but you'll look at the abdomen and something is different. It's an abnormal uterine shape. You can do a vaginal exam, and the station's going to start, baby's going to start getting higher and higher, or it'll be gone because it's inside the abdomen. That's a fetal emergency. C-section's happening promptly. We also need to make sure that they're relaxed. You give them an epidural if they want it, and make sure that our OBGYN is in-house in case there's any kind of complications. Here's the slide that goes with an umbilical cord prolapse. I've talked to you about it. I have a story that goes with it that will make you and help you understand this concept. We're getting close to the end of the lecture. Hang in there, you guys. I know that you're able to stop because it's a recorded lecture, but still. Okay. So umbilical cord prolapse, it's an emergency because look what's happening. You have this baby that's head is down. The umbilical cord, which should be up like this, right, now is coming out. So I'm going to ask you a question. What do you think is happening to the heart rate when the baby's head is compressing and cutting off circulation to the umbilical cord? What happens to the heart rate of the baby? I'm very, very confident that you're going to say the heart rate is going to go down or it's going to be gone. That's true. So how are you going to know this happens? The only way you're going to know is that all of a sudden, if you're looking at the fetal monitor strip, the baby's kind of plugging along at 130 or 140, and all of a sudden you're going to have terminal bradycardia because the baby is now compressing the umbilical cord. I'm going to talk about who's at risk, and then we're going to talk about my story, which will explain all of these things. Who's at risk for having an umbilical cord prolapse? Anybody who's ruptured. Certainly anybody who's ruptured with an unengaged baby. All right? Abnormal fetal lie, especially when ruptured. Transverse, oblique lie, footling breech, right? We talked about that already. Small for gestational age. Baby is too small to cork up the opening. Long umbilical cord and polyhydramnios. The reason for that is if polyhydramnios, right? Well, you know what that is. It's lots of amniotic fluid. But when somebody has polyhydramnios and their water breaks, it's like this whoosh of fluid. And the thinking is that the umbilical cord can come out in that whoosh of fluid. So here's my story. So if you don't know this yet, all the scary, complicated things happen at change of shift and at lunch when the charge nurse is breaking other people. So I sent somebody to lunch, and I got a report from the nurse that said my patient just got an epidural. They're sleeping. Her husband is sleeping in the partner chair in there. They're fine. Okay, great. The nurse goes to lunch. I'm watching the baby on the strip at the desk, and all of a sudden I see terminal bradycardia. And she's sleeping. And she hasn't met me yet. I go in, I turn the light on, I introduce myself, and I already know that this has happened, by the way, because as the longer you're a nurse, you can kind of grow your gut about these kinds of things. And her husband's asleep in the corner. I wake her up, and this is all happening really fast, even though my story is not so fast. And I put a glove on. And she says to me, maybe I think my water broke, which is exactly what happened. So I put my glove on, and I put my fingers here inside, and I ran into the umbilical cord first, right? And then with my 2 fingers, I pushed the baby's head off the umbilical cord. What do you think happens? The heart rate goes right back up because it's no longer compressed here. However, if I take my hands out, the kid's going to fall back on its cord. So basically, I always say that an umbilical cord prolapse is kind of like a finder's keepers kind of a thing, right? So now I'm stuck. The baby's going to be just fine as long as I never, ever leave
my position, but I can't do that. So what I did to her is I said to her, I said, what's your husband's name? And she told me, and I said, so and so, wake up, come here. So he comes over. Baby's still fine. I can feel the heart rate in my hand because the umbilical cord is in my, in my hand as I'm checking the patient. The loop is kind of looped into the palm of my hand. I said to her, well, here's what happened. Your baby is fine. And by now her husband's next to her. And I said, when your water broke, the umbilical cord came out in front of the baby's head. So if I take my hand out of your body, the umbilical cord gets squished by the baby's head and the heart rate is low. So I have to stay in here and hold the baby up with my 2 fingers. Baby is fine. However, you have to have a C-section. So tell them that. Make sure when you talk, and just kind of keep your voice as calm as you can, because this is a life-threatening emergency. So we want to make sure that your patient's not flipping out because you're flipping out, right? Keep control of your room when scary things happen. So I told the patient, I said, I want you to pull the call light out of the wall because the call light coming out of the wall is an emergency light. And then I had him go to the front of the head of the bed, you'll see in clinicals, and I said to him, you see those 2 handles there? I need you to push them down. What that does, you guys, that's how you put somebody in Trendelenburg position. So what I've done, I'm stuck there, but I'm using my resources. I'm getting help and I'm getting pressure off the baby's head. I'm already lifting the baby up, but I had him pull the emergency light or pull the call light out of the wall, and he put her in Trendelenburg. So now the Trendelenburg, the position of the patient, because she's in Trendelenburg now, backs the kid up higher into the uterus, so towards the fundus, but I still have to keep the kid off the cord. So now I tell my patient, in a second, you're going to have all kinds of nurses coming in. If you get overwhelmed, just close your eyes. Okay, we're here. The baby's okay right now. So everybody comes in, and I say, I have a cord. And that's all I'm saying, right? Because again, I have to, if I'm flipping out and stressed out, my patients are going to be all stressed out. And I need her to listen to me so I can take good care of her. So what happened so they put a Foley in her, consented her for surgery, and then we went down to the operating room. Again, I can't come out, right? My hand is still holding the baby up. So they kind of put blankets around us, and I can feel the baby's heart rate in the umbilical cord. It's pulsing in my hand, so I know the baby's fine. So we go down the hall to the operating room. We put the baby, and again, my hand doesn't come out until the baby's born, by the way. Baby goes onto the operating room table. My fingers are still inside holding the baby up, and I'm just yelling out heart rates here and there. So everybody knows that the baby is okay, as long as I'm okay in there. The docs come in. Everything's happening around me. My head's under the drape because my only job at that point is to keep the baby alive, which is what I'm doing. So everything's happening around me. They really quick go through the counts. They do their timeout. They start the surgery. I'm not allowed to leave my spot under the drape with my hand inside her vagina, right, holding the baby up off the cord until the doc tells me, okay, you can go, because that means now the doc is holding the baby and taking it out of the uterus. All right, baby was born, it was just fine. Okay, so that whole story took about 3 minutes. All right, so what is your responsibility as a student if this happens? Your responsibility is to watch and get out of the way. But I want you to watch because it's going to be the exact same scenario that I just told you. A couple of variances here and there, but I want you to watch and make sure you get out of the way so they can save the baby's life, okay? Meconium stained fluid is our next complication. So meconium stained fluid. So babies ideally pass their first stool when they're outside of their parent, right? But here, when you have meconium stained fluid, they pass the meconium in utero when they're still pregnant. Most of the time, babies are just fine, okay? So why does a baby pass their meconium inside? If they're overdue or if they're getting close to their due date. The closer you are to the due date or the over you are from your due date, the baby's gut becomes mature. And the baby is telling itself, well, I should be outside of my mom now, so it's okay if I start pooping because she shouldn't still be pregnant. So because the gut's mature, babies will start pooping. That's one reason. Also, if there's been an insult like umbilical cord compression, that it can stress the baby out and it can pass its first stool because it stimulates vasovagal in the baby, okay? How will you know? The amniotic fluid is not clear. We already talked about that. What do you do about it? Nothing. It's already happened. Oftentimes at most hospitals, they're going to have the neonatal team there just in case. Remember, the first breath the baby takes is the one that you hear. It is not breathing air. Amniotic fluid is already inside the baby's lungs. When the baby is out, when it takes that first breath and then starts crying, wah, 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 when it takes that big breath in, it pushes the amniotic fluid lower into the lower alveolar spaces of the lungs, and that's when you can have meconium aspiration. Okay, not all baby that are born with meconium stained fluid aspirate it. It just depends. Ideally, they don't. Ideally, we can get them suctioned before they take that nice big breath. If the kid comes out and is not breathing, we're going to start NRP and resuscitate the baby. If the kid comes out and it's breathing, we just do our normal stuff. Okay? Something that I need you to be aware of is something called vena cava syndrome. So somebody that's especially in their third trimester, end of the second, and then all throughout the third, you never lay that patient flat on their back. The reason is because you've got this gravid uterus full of a baby, amniotic fluid, and a placenta. And here's your vena cava right here, right? This is the circulatory system. When you lay her flat, this big gravid uterus compresses this vena cava against the spine, and she's going to feel real dizzy right away. The best way to fix this is to put a wedge under her hip. As soon as you move the baby off of the vena cava, she feels just fine. Okay? So most of the time, this happens when somebody has an epidural and the nurse leaves them flat. All right? So what the patient will do is they will put their collar on and say, I don't feel good. I feel dizzy. I'm ringing in my ears. The first thing you're going to want to do as a med-surg nurse is to go take their vitals. Vitals are very important. But I'll tell you what, as soon as you walk in and see that she's flat, put her on her side. Immediately, that displaces this uterus. The blood flow goes right back up to her head and she feels fine. If not, she's going to pass out. Okay? So that's that. You'll notice when somebody's having a C-section, the table is always at a tilt because you don't want somebody flat when they're in their third trimester of pregnancy. Fetal distress, as we round this lecture up, this is the normal fetal heart rate, 110 to 160. So some of these words we're teaching you about at orientation, like variability. You don't know what that means today, but that's the beat to beat. That's the variability, the squiggly lines. So fetal distress is distinguished as a fetal heart rate below 110, decrease or absent fetal heart rate variability, okay? And these things we're teaching you all about in orientation, so put a pin in this, okay? What do you do to resuscitate a baby when it's inside its mom? You have to resuscitate through the mom, okay? So we call that intrauterine resuscitation. Always least invasive to most invasives. Put them on their side, okay? That will help, left, right, depending. Give them O2 by a tight face mask at 10 liters. We're not using nasal cannulas. We're not doing 2 liters. Make sure you let them know there's a lot of air coming through the mask and take nice deep breaths. Babies love it. We can give meds to reverse tachysystole. You know what tachysystole is. If that's happening, that's the next slide. If we have Pitocin going and we have tachysystole happening, stop the Pitocin because the Pitocin is causing the tachysystole. Give an IV fluid bolus. If we can't fix it, they have to have a C-section. All right, so we're still talking about fetal distress. So here's this word again, tachysystole, and you already know what it is, okay? If somebody's having tachysystole, give them an IV fluid bolus. Put them on their side. If they're on medication that causes contractions, stop it. And I told you what those medications are. If that doesn't work, you're going to give them a shot of terbutaline. It is a tocolytic. Tocolytic. This word's going to come up over and over again at our time together. Terbutaline is I wrote it right there. Terbutaline stops our contractions, okay? And it's always given in this dose and always given in this route. Before we go into the strip, these are the biggest side effects of this tocolytic: tachycardia and jitteriness and shortness of breath and a headache. She will start feeling jittery within 10 minutes you give this to your person. Let them know they're going to feel jittery. And this honestly only lasts about a half an hour. The therapeutic effects don't last that long. If your patient, before you give it, most of your EMARs have a stop. That means you have to document the heart rate of your patient before you give it. If their heart rate's over 120 beats per minute, you cannot give it because this causes tachycardia, okay? All right, so let's look at this. So you don't know what this means yet, but I'm going to tell you right now. This is what is called as a late deceleration, a late decel, because it goes down from your baseline after the contraction. The rest you're going to learn about in orientation. So our baby all of a sudden is having lates. That's not good. And if you look and see, what's the resting tone here? This one's a long one, 10, 20, 30, 40, 50. This resting tone is 50 seconds. Where's a short one? This one, 20. This one, 20. Our frequency is very, very close together. Remember, I told you we at least want a minute in between the contractions. This baby is starting to show compensation because our contractions are too close together. Ideally, us as a labor nurse, we're going to stop this way before we start showing fetal compromise. Okay? This baby's being compromised because we didn't notice this. So what we're going to do is we're going to do all of these things here. We see tachysystole, noted. Give them an IV fluid bolus, put them on their side. If they're on medication that cause contractions, stop it. And we're going to, on our S-bar, right, our recommendation is going to be, can I get an order to give terbutaline? The next couple slides here, and then we're done, talk about something called shoulder dystocia. Okay, so when anybody's having a baby vaginally, when the head comes out, we as the healthcare team have 1 minute to get the rest of the body out. If the rest of the body does not come out, we have what is called a shoulder dystocia. A shoulder dystocia is an emergency. We don't want our baby to die. Babies who get stuck at the perineum die. Have I seen it before? Yes. Very, very rarely, though. I will tell you the things that we do, which is McRoberts, almost all the time will take care of this problem. Okay? The greatest risk factor of somebody developing shoulder dystocia is fetal macrosomia, which it says right there. All right, well, how do I know? Well, there hopefully is an ultrasound of the baby, right? We know that the plus or minus 2 pounds. So if the ultrasound says the baby's 9 pounds, it's either going to be 7 pounds or 11 pounds. Okay, so plus or minus 2 pounds on an ultrasound. They might measure the fundal height using a tape measure. And how you do that is you're measuring in centimeters. So you're going to take the 0 centimeter of the tape measure and you're going to put it at the pubic bone and you're going to pull it over to the fundus. And whatever the measuring is at the fundus should align with the gestational age of the pregnancy, plus or minus 2 weeks. So if your patient's measuring at 43 centimeters, but they're only 40 weeks pregnant, that's probably a big baby. Okay? So anyway, that's something for that. So let's say that we're not measuring big and we have no ultrasounds. We don't know how big the kid is. So what happens is that the nurse calls for the delivery team because the patient's dilated and fully dilated or crowning or whatever's happening with your patient. Part of that delivery team, ideally, you're going to have your healthcare provider who's delivering. You're going to have a team for the baby, right? And then in a perfect world, you have somebody like a resource nurse, or in most labor departments, your resource nurse is your charge nurse. And so your charge nurse would come in as well. And the charge nurse is there waiting for problems to happen. So everybody's there for the delivery. The head comes out. The labor nurse notes the time. And we have a minute to get the body out. If you've got somebody that has shoulder dystocia, what's happening is the turtle sign. So what's happening here, look at the shoulder. The shoulder is trapped behind the pubic bone of the mom. So she's going to keep pushing and pushing, but the head's coming out and going back in, coming out because the shoulder can't get past. It's stuck here. So we have what's called a turtle sign. So what we're going to do once we diagnose it, the doc's going to say we have a shoulder dystocia, so we got to make sure we get help in there. And the next slide talks about what we do about that. So this is McRoberts. So this is somebody who's up on the stirrups, right? And they're pushing and pushing, but now the baby's stuck. Here's the baby and it's stuck. So we're going to get our resources in the room, and then we're going to put our patient in McRoberts. What you're going to do is you're going to try to get their knees as close to their ears as you can. And what that does is it puts the pelvis this way and it opens up the pelvis. It tilts the pelvis because you're pushing the knees back, opens up the opening, and the baby can come out a little easier that way. Okay? That is McRoberts. That most of the time that works. Sometimes that isn't even enough. So sometimes what you'll do is you'll have your resource person who's your charge nurse. You want to get, the charge nurse will get up above the patient and they're going to put their, so here's the baby, right? You go back to the previous slide, you can see it. And I don't want to go back and forth, but the shoulder is stuck here. So if I am the resource, I'm the charge nurse, I'm coming in, I'm getting up on the bed or up on a stool and I'm standing above my patient and I'm taking my hand and I'm pushing right here. What I'm doing is I'm pushing the baby's shoulder. So as she's pushing, your patient's pushing, I'm pushing here and I'm trying to dislodge that shoulder from around the pubic bone. Okay? That works almost all the time. If that doesn't work, what will happen next is the healthcare provider, the delivering person, will reach in and they're going to break this clavicle on the baby's shoulder. Now, to you, that might sound really, really sad. And it is. We don't want any broken bones. It's a complication here. We also don't want a dead baby, right? So we want to break the clavicle. And what happens when you break the clavicle here, the shoulder collapses and the kid can come out. And then we go ahead and help the baby because it's out and it's alive. It just has a broken shoulder. So what they'll do is they're going to, babies, because their bones are so, they're pliable, they're softer, when they're newborn like that. So with neonates, what they're going to do is they're going to get like a wrap, if you will, and they're going to put the arm almost like you're crossing your heart, right? They're going to put the arm and on the chest and they're going to wrap it, and the baby will be immobile for a little while, and then it'll be just fine. This concludes our lecture.